us. It is great pleasure for us from Shield to welcome each one of you for today's webinar, which is task started, organized by the Society. And it is a great honor for us and thank the society for giving this opportunity to us. And I have been given the privilege of introducing Dr. Kavita Banwal, Madam. Of course, everybody knows about Madam. Just a few words about Dr. Kavita Banwal, the Secretary of Bhagalpur OG Society. She has won many awards, member of life member in many of the organizations, and member of YTP Committee of Foxy 21-22. Most important point I wanted to highlight about Dr. Kavita is she has done a lot of work in empowering many underprivileged and rural women, and a great environmentalist. Her special area of interest is high-risk obstetrics and hysteroscopy. With this, I hand over the session to Dr. Kavita Banwal. Once again, and thank all the delegates and faculty for giving this opportunity to share. Thank you very much, Doctor.
Thank you, Balaji, for your good words. Namaste and good evening. Respected Chief Guest Alka Kripalani Madam, Guest of Honor Baso Mukherjee Sir, Chairperson Adolescent Health Committee Girish Mane Sir, Pramila Modi Madam, Rajni Madam, all the esteemed faculties and dignitaries as well as delegates. Today we are going to have webinar on very important topic, that is adolescent health. The teens are emotionally unstable and pathetic. Adolescence represents an inner emotional upheaval, struggle between the eternal human wishes and cling to the past, as well as equally powerful wish to get on with future. So we will learn many new things on adolescent health, and now we will start our event by lighting the lamp, which symbolizes the spread of wisdom and knowledge. So please, start lamp lighting.
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam.
Thank you. Now I invite, please share the slide of Rekhaja Madam. Our dynamic President Rekhaja Madam, a true leader and very hardworking, patron and life member of many organizations. She was RCS coordinator in 1997. She has served Bhagalpur Afghani Society and IMA by holding many posts, including Secretary, Vice President. She is patron and life member of many organizations, including Chief Health Officer, International Human Rights and Anti-Corruption Bureau, India. So I request Rekhaja Madam to welcome the dignitaries and also introduce the chief guest of today's evening, Alka Kripalani Madam.
Ma'am, please unmute yourselves, ma'am. Rekha, ma'am.
Thank you, Kavita. I'm honored to have this meeting of Bhagalpur Ops Gynae Society together with the Adolescent Health Committee of Foxy. And I would like to introduce Dr. Alka Kripalani Madam, who is the past president. Can I get the slide of Dr. Alka? Yeah, she has been the past President Foxy in 2016, President JC Gynecological Endocrine Society of India in 2011 and continuing still. She has been President DGES, Delhi Gynecological Endoscopic Society from 14 to 16 and President AOGD, Association of Obstetricians and Gynecologists of Delhi 2013 to 14. Editor Asian Journal of Obstetrics and Gynecological Practice 99 to 17 and on the editorial board of 9 journals. She has co-chaired FIGO Menstrual Disorder Committee in 16-18. Awards, she has got total 47 awards and the highest ones are Padma Shri, Dr. B.C. Roy National Award, Honorary FRCOG, DMA Medical Teachers Award, DMA Chikitsa Ratan Award, IMA Mrtyunjay Divas Award, Rashtriya Gaurav Award, Vidya Vibhushan Award, ICOG, CNBC Award, FIGO Award. In 2021, ET Economic Times Most Inspiring Gynecologist of North India 18, guest lectures 906, orations 72, live workshops 156, scientific publications 405, and organized conferences and workshops 130. Field of interest is gynecological endoscopy, reproductive endocrinology, and high-risk pregnancy. So, Dr. Alka Kriplani, madam, I am honored to read out your CV only, and welcome once again to our Bhagalpur Society. We are trying to do whatever we can together, joining hands with the higher ups in the FOGSI, so that gradually we climb up some steps and be known to everybody. That is only the motto with which I am leading this organization in Bhagalpur. And with these words, I will invite you, madam, to say a few words and to be always with us.
Thank you so much for your kind introduction, Dr. Rekha Jha. I am moved with your humbleness and the honest confession what you want, and I really appreciate Bhagalpur Society. Yesterday also I was with you, and I think you, President Rekha, and the Secretary Kavita, and Pratibha, and the team Bhagalpur, you are the most aggressive and hardworking girls who are bringing Bhagalpur to the national map. I can see your efforts. It requires so much of coordination. So I really appreciate this office-bearing team of Bhagalpur Society. And today's topic is adolescent. This topic is very, very pertinent. Actually, adolescent population is in very high number. If we take care of adolescent population, then our, it will be a very good preventive strategy, because anemia in adolescents, AUB in adolescents, if it is taken care at that time, the health of the girl will all along her reproductive years will be very, very helpful for her reproductive career. So I really congratulate the Bhagalpur Society for this wonderful choice of the subject, wonderful team, official team, President Rekha and Dr. Kavita. And yesterday I met another very active Bhagalpur girl, Dr. Pratibha. And I really wish you great success for this webinar. And many more societies should be as aggressive, as active academically as you people have made Bhagalpur. So I wish you all the best and great success for this webinar. Thank you for inviting me.
Thank you, madam.
Thank you, madam, for your kind words and for your blessings. We are really honored to hear you. And thank you, Rekha madam. Now I invite guest of honor of today's evening, our Vice President of East Zone, Dr. Basa Mukherjee sir. He is very active, very disciplined, and he has served Bengal Afghani Society by holding many posts. He was FIGO Coordinator South Asia for Safe Abortion Committee, Founder Secretary ASOPA Kolkata Chapter, Founder Secretary IIG Kolkata Chapter, Secretary IRC India East, Member ICOG Governing Council for 5 years from 15 to 20, organizing secretary for ASCOG 2023, which is going to be held in Calcutta. And he is the recipient of Young Gynecologist Award, AFOG 2011 at Taipei, and he has contributed more than 30 chapters in textbooks. So I request with great honor Baso sir to bless our society and to guide us.
Hello, Dr. Kavita. So nice to connect again with Bhagalpur. I think, as Dr. Alka said, I think Bhagalpur is moved up several notches under your leadership and the previous leadership over the last 3 to 4 years. You are much more prominent than what you were before. And thanks to all the wonderful people of you. And I think there's a competition on, if there was the best secretary, I think Dr. Kavita, you would be very close competition with Supriya for that. I think Supriya, so best secretary of the year we don't have in Foxy, but you and Supriya have done enormous amount of work, Patna and Bhagalpur, in this last few months and year what we've seen. You guys are doing an enormous job. About Dr. Alka's CV is something which I've preserved, because that is a CV which, if there's any talk which I need to give on how high you can reach in your achievements, I think that would be something which is a benchmark. Because Dr. Alka's CV is, I think there's some of the top most, I think there's very little which you can go above that. So that's something which I have preserved. Dr. Alka's CV is something very special. Girish is here. Today, something, because it's Adolescent Health, I just want to share something with you people. And I think it may be worth looking at, listening to. Today, I was at a house for transgenders. Transgenders is something which we have not done any work with. And it was through Rotary and also through even through Foxy. I think LGBTQI community is something which I think we need also to pay some attention as doctors and as social responsible citizens. I think we have not done much, both as well as Foxy or as well as Rotary. I understood that they had an immensely marginalized community and they have a lot of needs. So there's a lot of things which we can do in that level. Transgenders are a different species together, and we don't understand anything about them. That's what I realized when I went today. And it is something that they have so much of different mindsets and so much of reproductive issues which they face and which they have, that they need a lot of help from our side. But you're doing wonderful work. Adolescent health needs to be discussed, time immemorial, and it continues. The discussion has to go on. You've got some wonderful faculty. Dr. Sharmila is here, I can see, and they will lead a wonderful academic discussion. So thank you for calling me again. I love to be there in Bhagalpur, but I think it's time now I stop the virtual and get into the physical mode. I think all of us are slowly getting into the physical mode. I'd love to come to Bhagalpur sometime before I finish my vice president at the end of the year in October. It'll be a wonderful opportunity to go and meet you all in person, because we have interacted so much in the last 1 year through the things. So all the best to all your candidates who are standing. Dr. Anju, Dr. Pratibha, my best wishes go out to you, and good luck for the Fox elections. Thank you very much, and look forward to good academia. Thank you.
Thank you. Thank you so much for your inspiring words. Yeah, we will try to meet you personally, and we will organize such webinar. See, in a few months after, I think this ASCOG gets over.
Physical
so now,
conference.
Yeah, after the annual conference. Yeah. So now I invite our own member, Dr. Pratibha Singhdi. He is very active, dynamic member, so hardworking. He used to be busy in every day's webinar. I don't know how she manages. And she is consultant laparoscopy gynecologist and IVF specialist, trained in many things from different places like Germany and Dubai. And she has won many awards. She has been secretary for AOGSBJ for 11 years, from 2008 to 19, and she is organizing person of many conferences in our part. And her field of interest is high risk pregnancy, endoscopy, and fertility. And she has honor of giving first IVF baby in Eastern Bihar and Jharkhand. And last but not least, she is candidate for IAEC, International Academic Exchange Committee. And I request all of you from the core of heart to bless our society and to bless her, so that she can win. She is first candidate who is going to fight for chairperson of any committee. So with these words, I request Pratibha Singhdi to conduct the scientific sessions which are going to held just now. So Pratibha,
thank you, Dr. Kavita, for such kind words, and thank you so much. So good evening and warm welcome to all of you, and my regards to our guest, Dr. Alka Kriplani, madam. It was a wonderful opportunity to meet you again in quick succession. So keep blessing us like this, madam, again and again. Now my regards to Dr. Basav Mukherjee, who is always there to encourage us to organize such program, and he has already promised us that he'll be coming to Bhagalpur. So welcome to Bhagalpur also, Dr. Basav. We will definitely organize one program such. And so thank you, sir, for always appreciating us. Now we have another guest today who is new to Bhagalpur. I think for the first time he is visiting Bhagalpur virtually, but he's a very well-known personality, very popular face of Foxy, and a very versatile and cheerful personality, Dr. Girish Mane, Chairperson, Adolescent Health Committee, Foxy. And although I know it is really difficult to reach Bhagalpur from your place, Dr. Girish, but then this webinar has made this possible. And so welcome to Bhagalpur today virtually. So welcome here. And the honor of officially introducing him will be done by one of our chairperson for the next session. But definitely here I just want to add one thing, that he is all-rounder, a great academician, a wonderful singer, a pleasing personality, and we keep listening his melodious numbers on and off. So it's wonderful. And so welcome, sir. And before you start your scientific talk, I will request you to please bless us with your some pearl of wisdom before we start your scientific session. So over to you, Dr.
Sure, sure. Thank you very much. Thank you, madam. Thank you for a very kind of mine. Thank you very much. Extend my sincere thanks to the team Bhagalpur, Dr. Rekha madam, Dr. Kavita madam. Also a very warm good evening to the
chairpersons.
Hello. Can you hear me?
Yeah, yes.
Yeah. And I extend my wishes to Dr. Supriya and Dr. Pratibha madam, who are going to fight for the post of chairperson. Definitely we are with you, nothing to worry. And once again, good evening to all the speakers, all the panelists, and all the viewers also. So let me start my...
Just a minute, Dr.
Sir, before that, I will request our chairperson. So I will just introduce our chairpersons before you start your scientific program, scientific session. So, sir, can
Again, I want to thank the team Bhagalpur just to select the subject for today's CME, which is very close to my heart, and really the adolescent care is a need of time nowadays, because just Alka madam has uttered that word that our India is having the highest number of young population. And really, if we are interested to take our India in front, then the care of this adolescent community is very, very essential. And thank you very much for selecting the adolescent health for the today's CME. Over to you, ma'am.
So thank you so much. Now we will start our scientific program. And our first speaker is Dr. Girish Mane. And to chair the session, we have equally experienced chairpersons. So it's my proud privilege to welcome our own guardian, Dr. Pramila Modi from Patna. So welcome, madam. And it's my proud privilege to introduce you. Dr. Pramila Modi is the consultant and obstetric gynecologist from Modi Nursing Home, Patna, honorary consultant, Arogya Mandir Sansthan, Patna. She has held a various organizational posts in Patna as well as in AICOG 2014 conference, which was held in Patna. She was vice chairperson during that time and also the scientific chair. Then she has number of publications and many awards to her credit, and her field of interest is public awareness in safe motherhood, contraception, midlife, and geriatric gynecology. So I welcome madam to this forum today to Bhagalpur. Thank you for joining. Now, our next chairperson is our own past president, Bhagalpur Obs Gynae Society, Dr. Anju Toriyar madam, who is very active in academic activities and making all of us proud. Dr. Anju, welcome to this forum today. She is the director of Matrit Clinic. She is ACMO Begusarai. She is the past president Boggs, past vice president AOG SBJ, and she was the zonal coordinator of Family Welfare Committee. She was very active during last of her tenure, and she was also a recipient of Gynecologist Award for Community Service by Rotary Club of Vikramshila Ping. She has promotion of awareness regarding cervical cancer and breast cancer and their prevention. So with these words, I welcome both of you. Now I hand over the session to you, and I request Dr. Anju Toriyar madam to kindly introduce our speaker, Dr. Girish Mane.
Thank you, Pratibha, for your kind words. It's been so nice to see all of you again, and nice to introduce Dr. Girish. First of all, I thank Boggs Society, especially Dr. Rekha and Dr. Kavita for having me on this platform. And as Dr. Alka Kripalani ma'am and Dr. Basam Mukherjee, both of them have blessed our society. I do take their words so that our society will definitely grow up and up, large, flourish. Now coming to Dr. Girish Mane, who is a multifactorial, multitasking person and a very talented person. At present, he is the chairperson of Adolescent Health Committee, FOGSI. He's been the past president of Yavatmal's Obs Gynae Society, past chairperson, Adolescent Gynecological Committee, AMOGS. He received the award for Best Chairperson AMOGS in 2018 to 20. He is the recipient of FOGSI Smriti Mylan Save Baby Girl Runner-Up Award. He is also the recipient of Best Society Awards AMOGS in 2016-17. He also received the Duru Shah Youth Trophy and Dr. Sadhana Desai Trophy. He was the first winner of FOGSI Talent Singing Contest. Congratulations once again. He's contributed 5 chapters in FOGSI Focus. He's presented many papers in national and state conferences. He's the editor of FOGSI Focus, Adolescent Intervention for Future Reproduction. He is the editor of AMOGS Focus, Adolescent Healthcare, and also the editor of FOGSI FAQ, Adolescent Health. His topic is very important. The whole topic about adolescent girls is really important because it is the future of our country, future of our country and other countries also. Adolescent age is very important. And moreover, the technical point of view is there already, but the lawful points is also very important, which most of we doctors, we are unaware of these things. So now I introduce Dr. Girish Mane to the stage. Please enlighten us with these laws.
Thank you, madam. Thank you very much once again for kind introduction. So now I'll share my screen.
Just a minute, Girish.
Yes, ma'am, please.
Yeah. There is a little bit for me to speak as well.
Yes.
Definitely.
Respected Dr. Rekha Jha, President of Bhagalpur Society of Obstetrics and Gynecology, Padma Shri Dr. Alka Kripalani, past President FOGSI and Chief Guest of today's webinar. Dr. Basab, as we all know, is the guest of honor and Vice President of FOGSI as well. Dr. Girish Mane is our star speaker for today, and he has been very nicely introduced by Anju Turiyar. I would like to just say hello to many of the young talented girls, Kavita, Pratibha, Anju, Rajni Sharma from Patna, Poonam Dikshit, Supriya. I think the whole FOGSI members, they all now know Supriya, how dynamic she is. And I really wish all the best for Supriya and this thing, what is Kavita, na? Pratibha, all the best. And Lata, etc., all the viewers of the webinar, ladies and gentlemen, a very good evening to one and all. At the very outset, I thank the Bhagalpur Society for having this very nice, wonderful webinar, especially Dr. Rekha Jha for inviting me as chairperson of today's function, which is jointly organized by Bhagalpur Society and, of course, Adolescent Health Committee of FOGSI. As you know, the topic has been told, but it is such a big and vast topic. The topic has expanded like anything because the adolescents have to be reared in a proper manner so that they prove to be the good citizens of India and serve the humanity as well. So we are really eager to hear, Dr. Girish, what you have to say about the adolescent health and particularly the legal aspects of the adolescents, which they are to be, especially even we should know and even the adolescent girls should know. Over to Dr. Girish, please.
Thank you, ma'am. Thank you. It's been a pleasure to be a part of this CME. And today I'm going to speak something about the adolescents and laws. Thank you once again. Friends, at such, there are many laws we are practicing. They are applicable to all the gynecologists or all the doctors in our practice. So many laws there, for example, the MTP law, or there are many laws of, for PCP and DT, and there are so many laws. Maybe if you are not indulged with these cases, for example, if you are not doing MTP at all, if you are not doing sonography at all, then there is no need to worry about the PCP and DT or MTP, because you are not dealing these laws directly and you are not involving in these laws. But there are some laws and you are involved indirectly only because you are a gynecologist and you are dealing with the victims or the people who are for whom that these laws are, they are prepared. And that's why it is very important to know the laws. I always say that you cannot say in front of the court that I don't know the law, and ignorance can never be an excuse. It is your duty to know the laws, and that's why today we are focusing on few laws, and especially the POXO, which is very important. And just because you are a gynecologist, you are dealing with the girls who may be the victims of this POXO Act, and if you are not aware of your own duties as a gynecologist, then you can be in trouble without doing any harm or without doing any crime, but just only because you are not, or you were not aware of these laws. And that's why you should know this law for yourself. Then you should know the laws to make the society aware and to restructure the strategies for the adolescent health education. And let's discuss something about the laws. Today I'm going to talk something about which are the Indian laws which are related to the age. Then I'm going to elaborate the POXO Act, then what is the relation of the MTP and adolescents, and what is the duty of the health professional for the adolescents. Today we are going to discuss. Friends,
Sir, sorry to interrupt. Your slides are not moving, sir.
Yeah. You have to make it.
Sir, please stop share and share again, sir.
Oh, actually, oh, sure. Can you see now?
Just give me a minute, sir. We can see, sir, but not on slideshow mode.
Just a moment, I'm trying.
You make it slideshow here. You make
Yeah.
Full screen now. Yeah.
Is it visible now?
It's visible, sir, but not on slideshow mode, sir.
Now you again log off.
No, sir. Please stop share. While sharing again, don't click any icon, sir.
No. I got the thing. Actually,
okay, sir.
Those were open.
Great, sir.
Sure. Is it fine now?
No, sir.
Not on full screen, sir, again.
Sir, you have to make it full screen here and then stop share and then again directly you share.
Okay.
This is the drawback of virtual programs, you see. It happens many times.
So may I help you, sir?
Is it visible now?
Again, not in full screen, sir.
Dr. Girish, I can suggest you to maybe log out once and log in once more, maybe, sir. That will help.
Sure.
I guess you are selecting the icon. Please stop share, sir.
Yeah.
While sharing, don't click any icons like share screen and then blue color share. That's it. Don't click any other icons, sir.
Is it visible now?
Yes, sir. Perfect, sir.
Yes.
Correct?
Yes,
sir.
So it is very mandatory on our part to know few laws in which we are indulged indirectly without our knowledge. And I always say that there is no law to love the adolescents, and there is no law for their innocence, and there is no law for their clean heart. That's why it is our duty, the duty of the parents, the duty of the doctors, and the duty of the civilians to care them, to nurture them, and their health is a need of an hour, and that's why it is the bestest way to develop or to create the best future of our own India. Friends, this word adolescent, it is derived from this Latin word adolescere. Adolescere means to grow, to move up, and there are many rapid there are many changes in their physical growth, there are changes in their emotional status, their psychological and spiritual changes. So this is the division of the age from the 0 to 19 roughly. So these are the characteristics which I have put it in a mnemonic, that is adolescent in the Wipjob. Then now today, just let's discuss what is the relation of the age and the laws. As such, the laws, they are applicable since our birth. As you all know that nobody can abort a child about 24 weeks. So the age and the law, it starts since I can say even before the birth. Then 12 is the age where the person starts to get favor of all the Indian laws. The consent for the examination can be given after 12 years. Then nobody can give the factory job to anyone, either male or female girls, girls or the boys below 14 years of the age. Then 14 to 15, one can do the non-hazardous works with the limited hours. And any person can work in a factory above 15, but they need to have the fitness certificates. And no work below the ground, I mean, especially in the mines, can be offered to the boys or the girls below 17 years. Then in India, 18 is the age of maturity. The boys, they can marry at the age of 21 years, and the girls can marry after 18 years. Then consent for the surgery or any other hazardous job can be given only after 18 years. And if the boy or the girl, they are below 18 or 18 years of the age, then the consent of the parents or the near people is required according to the Indian law. Then person can make a lawful will after 18 years of the age. Then they are defined as a juvenile offender if they are doing offense below the age of 18, and they cannot be sent to the jail if they are below 18 years of the age. And if they are below the 18 years of the age, then they have to send to the hostel or the reforming school. So there are many tricky situations in our day-to-day practice. As I already told you that a boy or a girl can give the consent for the examination if they are about 12 years of the age. But as such, the law says that the consent of the parent is always needed if the boy or the girl, if they are below 18 years of the age. Now, in a situation where the parents, they are refusing the examination of the boy or the girl, but if that kid, they are ready for the examination, then what? So such tricky situations we are facing in our practice day-to-day practice. So this is what I just told you, that juvenile delinquency. Now, what are the Indian laws which are related to the adolescents? So Child Labor Act, Child Labor Prohibition and Prevention Act 1986, then the Immortal Trafficking Act, then the Indian Penal Code, it also take care of the adolescents and their issues. Then the Juvenile Justice Act, which was developed in 2000 and which was again amended in 2015. Then the Prohibition of the Child Marriage Act 2006, the POXO Act 2012, which was again amended in 2019. Then the MTP Act, as you all know. Then the Information Technology Act 2000. Then the adolescent, there is one law for the adolescent abuse also. Then the Drug Abuse, the Cigarette and Tobacco Act 2003, it is also applicable to the adolescents. And the Criminal Law Amendment Act 2030, which is for the consent of the sex, which is above 18 years of the age. So these are the laws which are related to the adolescents. Now let's discuss the most important law which every gynecologist should know, because we are dealing with such kind of the cases. That is the Protection of Children from Sexual Offences Act 2012, which was amended in 2019 in regards to the crime and their penalties. So before talking anything, I would like to put this disclaimer that these are my own and personal views after reading 173 pages of the book, which was given to me by one lawyer. Then I may differ at some points, and you can correct me, you can correct my the views. Then everybody is most welcome for their suggestion and advices. And the last request to everyone, please follow the POXO Act and POXO law in your practice very strictly, because even if you are not getting any harm today, this law can make you behind the bar after 10 years, 15 years, 20 years, whatever. So please try to understand the law and please follow the law in your practice very strictly. So my very important questions to all of you: have you ever had a married lady of 18 years for the delivery or MTP? Then have you had any unmarried girl below the years of 18 years for MTP? Or have you ever diagnosed pregnancy in a girl who is below 18 years, not only by the clinically, but either by USG or by UPT? Have you ever had an unmarried girl with the complications of MTP? Means you have not done MTP, but she's coming to you and you have diagnosed the complications of MTP. Then have you ever given the prescription of contraception to a girl below 18 years of the age? And the very next question, have you informed to the police? And friends, if you have not informed to the police, then this can be the situation, a doctor behind the bar. So let's discuss the POXO Act. As I already told you, that ignorance of the law can never be an excuse. It is your duty to know the law. Law will never come to your doors. It is your duty because you are dealing with the patients who can be the victims of this POXO. There are many aspects in the POXO Act, but you should know this law to some extent. You should at least know what is your own role. You may not be aware of or you should never go in details of what the police they should do, or what is the duty of court and all. But at least you should know what is your own role. Then you should know about the compulsory reporting of the cases. Then you should know some changes in the examination of the victim, because you may do some problems with the POXO. Then there are some controversies or some difficult situations we are going to discuss today. Friends, I always say that definitely save the girls. It is your duty. But before saving these girls, please think of yourself and save your skin first. There is a huge violence against children in India, as you can see on the slide. I won't go in detail. And mostly the crime against the girls, especially, or the boys below the 18 years of the age, they are done by mostly the known people. And it is said that almost 28% of the girls, they are abused between the age of 8 and 16. There are approximately 5 million child commercial sex workers below 18 years. And it is about 40% of the total population of the commercial sex workers in India. And most of the girls, they are from the metro cities, and all. So there are already lots of provisions under the Indian Penal Code 1860. For example, for the rape, for the kidnapping, for molestation, for sexual harassment. Then why there is a need of this POXO Act 2012? Friends, as you all know, that Nirbhaya Kand, which was very immediate and which was very, easily, like diagnosable or whatever, it should have been dealt in the court. But it also took a long time for to end that or to close that case. And that's why the Indian Penal Code activities, they are going very slow. And that's why there is no, there was a need of some special law for the adolescent or any person who is below 18 years of the age. And there is no law which is taking care of the sexual offenses against the children, specific law. Then there is no specific provision or law in the Indian Penal Code to deal with the sexual abuse against the male children. And as I said, that IPC, they take very long duration, and that's why there was a need of development of this POXO Act. And according to the POXO Act, any person who is below the years of 18, they are termed as a child. Officially, this POXO Act 2012, it was published in the Gazette on 20th of June 2012, and it was brought into the force from 14th of November 2012, and popularly it is called as POXO Act and not a POSCO Act. There are a lot of salient features of this act. You can read on the screen. I won't go in detail. There are new offenses, new special codes. The reporting is absolutely mandatory. And if some person is not reporting to the police or SGPU, then the punishment is there. Then these law, they are monitored by the NCPCR, or it has convergence with the Justice and Juvenile Act. Then there is a provision of compensation to the victim from the court. So these are some important aspects of this POXO Act. And sexual offenses in the IPC, they are gender specific. They are developed for the women or for the girls. But this POXO Act is applicable for the boys as well as for the girls. Then POXO Act is only applicable to the child survivor and adult offenders. And if the survivor or the person who is a victim and the person who is doing or who is the offender, if both they are child, then the case will handle the Justice Juvenile Act will be applicable in such cases. And everybody should know that after independence and adoption of the Indian Constitution in 1950, the Child Marriage Act has undergone several revisions. And in India, the minimum legal age for the marriage for the boys is 21 and for the girls is 18. And the age of consent for the sex in India, according to the Criminal Law Amendment Act 2013, is 18 years. And below 18 years, nobody can give the consent for the sex. And if at all there is a consensual sex, the law will never take it as a lawful consent. And that's why the POXO Act covers everyone who is below 18 years of the age. Now, what are the offenses under POXO Act? These are the offenses: penetrative sexual assault, aggravated penetrative sexual assault, sexual assault, sexual harassment, and even using the child for the pornography or preserving the pornographic material which are involving the child. These are the offenses. These are the punishment up to the 3 years, 7 years, may not be with a fine. And even the law is applicable for even abatement. Abatement means to provoke. For example, if some person is making any boy or a girl to indulge in a sexual activity, then that person will be taken as a guilty for the POXO, and definitely the penalty can be there. So child trafficking is also covered in the abatement. Then even if somebody is attempting to commit an offense, they are also penalized. At least for half of the punishment they can be given. Now let's discuss this part, that is mandatory reporting. It is definitely not mandatory on the for the all person to report a sexual violence against the adult woman. The hospitals, they are obliged from this according to the Indian Penal Code 357C CRPC, but it is absolutely mandatory for every person to report the case of sexual offense against the children. Not only the sexual offense, but even if there is consensual involvement of a boy or a girl in the sexual activity below years of the 18, and if you are known about that fact, and even if you are apprehended for that fact, you have to inform to the either local police or to the special juvenile police unit. But unfortunately, the special juvenile police units are not developed everywhere. Usually they are in the metro cities, but small cities like Yavatmal, we have to inform to the local police. Now, how to report and when to report the offense? One can report the offense by registering an FIR. In the book, it is said that you can lodge the FIR orally also, but I will definitely suggest you that it should be in written, because whenever the case will go in the court of law, it is your duty to prove that you have informed to the police, and it is not the duty of the police to to prove that you have informed or not. And that's why if it is given in written, then it's fine. It is called as first information report, and the FIR should be signed by the informant whenever it is given in written. Then the response of the local police should be stated, because if they are not taking your case, then you can apply to the senior one. Or if nobody is taking the cognizance of your FIR, then preserve that copy and call on 1089 or 100, or you can send, because these are the bestest evidence that you have already informed to the police. And some important suggestion: avoid delay in approaching to the police. It is very strongly recommended, and the reporting is absolutely mandatory. Please, if you are trying to give up these suggestions, then again I am showing this picture, that a doctor with stethoscope and a doctor with hatkadi. And if you are doing failure in the reporting of the cases, then the person is punishable for the imprisonment of 6 months और विथ फाइन और बोथ. मतलब अगर आपने एक बच्चे का सेक्सुअल इन्वॉल्वमेंट का अगर पुलिस को नहीं बताया, तो एक हाउस पोस्ट आपको जेल के अंदर करनी पड़ेगी. यहाँ पे स्टाइपेंड आपको मिलेगा नहीं, आपको देना पड़ेगा. सो प्लीज व्हेनेवर यू आर कमिंग अक्रॉस सच काइंड ऑफ द केसेस, इमीडिएटली इन्फॉर्म टू द पुलिस एंड डोंट बॉदर कि ये मेरे पहचान की है या मेरे पेशेंट है, इनके यहाँ की सारी डिलीवरीज मेरे यहाँ होती है, इसकी मम्मी का ऑपरेशन मैंने किया. डोंट बॉदर. प्लीज टेक योर केयर फर्स्ट एंड देन थिंक ऑफ योर पेशेंट, because the law is to prevent the involvement of the girls and the boys in the sexual activities below 18 years of the age. And as the responsible this Indian citizen, it is our duty to follow the laws which are made for the betterment of this children. And failure to report the offense committed by the subordinate or by a person in an institution, then the person who is in charge of that company or that institution, they are punishable with the imprisonment of 1 year and fine. And that's why whoever are the head of the departments of any OBGY society or in anywhere where these cases they can come, they should keep in this mind that they are punishable for 1 year, and their subordinates, they will never be taken as a guilty. And if the false complaint is done against any person or against children, then the person will be punishable up to the imprisonment of 6 months with fine or both. But no civil or criminal liability is there if you are doing this thing in a good faith. but it is your duty to prove that whatever you have done, what it was in a good faith. So if the things are done maliciously, then definitely the imprisonment of 6 months is there for the person who is doing that. There are some directions to the media. Media cannot disclose the identity of that boy or a girl in any form, either by the name or the address or photograph or relatives, in any form. If they are doing that, then they are punishable for the imprisonment of 6 months, which can be even extended up to 1 year. Then there are some special procedures for recording the statement of the child, that for example, the recording should be done in the residence of that boy or a girl. Then if the victim is a girl, then it should be done by lady officer. Preferably she should not wear the uniform, she should be in a civil dress. Then it should be done in the presence of the parents or any other person in whom that child, he or she, they are having trust and confidence. Then assistance of the translator or the interpreter can be taken. Then special educator in such cases can be applied. Then wherever possible, recording should be done in an audio visual or electronic mode for the betterment, for the better utility in the court of law. Then it should be written in a way what that child, he or she spoke. Now coming to the medical examination, these are the principles and the right of the boys or the girls, which are in the best interest of their child. The medical examination of the rape of victim, as you all know, it should be done by RMP after receiving the FIR. The RMP should write the name, the address of that person or that victim, and the person who have brought that lady for the examination. Then the age and consent should be done. Then if asked for, then for the DNA profiling, the material should be collected. The marks of injury should be noted. Then the general mental condition should be noted. Then the other particulars, if they are asked for, should be given with the reasonable details, and the report should be forwarded by the RMO. But what are the changes? Then coming to the medical examination of POCSO, there are small changes. Number one, examination has to be conducted even if there is no FIR or complainant copy, and should be done within 24 hours. You cannot examine the person or the victim of the rape without FIR, but in POCSO you have to examine the girl or the boy even if there is no FIR with them. Then in case of the girl child, the examination should be done only by lady doctor, and if there is no lady doctor in the institution, then you have to refer that that girl back to the police station. You cannot examine. Then medical examination in the presence of the parents is mandatory, and if the parents, they are absent, then the medical examination should be done in the presence of a woman who is nominated by head of the medical institution. Many times what happens, the parents, they are guilty. I mean, you must have come across some cases where the father has raped the child, and in such cases, if the police department feels that that girl is not easy, or she is not easy with the presence of their parents, then the examination or the whole thing should be done in the presence of a woman who is nominated by the head of the institution. Then what if the emergency medical care is needed? In such cases, even the male doctors can give the emergency medical care. Not can give, they have to give, because many times there are the boys or the girls, they faces some injuries, then the cuts, bruises. Sometimes history of the HIV can be there to the person who has raped that girl. That's why the prophylaxis is needed, and in such cases, if needed at all, the emergency medical care should be given by the male doctor. Now coming to the difficult situations, friends, as you all know, that MTP Act says that we have to maintain the confidentiality of your patient. We cannot disclose the name of our patient to anybody other than some specific people, for example, appropriate authority or to the court. But POCSO Act says that it is mandatory to report that boy or that girl. So which law we should follow? So in such cases, if you are doing MTP of that girl, but if she is below 18 years of the age, you have to inform to the police. You have to follow the POCSO Act, because it superpowers the MTP Act, and it is from 2012, and that's why you have to inform to the police. And one more important thing, you have not to inform to the police that you are doing MTP, and police is not, the permission. Then situation number 2, it would be illegal to do anything without the consent of a person, isn't it? But it is mandatory to inform to the police regardless of the consent being taken or not, according to the POCSO. Now this puts the doctor in dilemma when the relatives, they don't want the criminal investigation, and they are not giving either written or the verbal consent to you. Now what to do in such cases? Even though you are not getting the consent from the parents, you have to inform to the police according to the POCSO Act. Don't think about the consent from that child or the parents. Then what if the child is about 12 but below 18 years of the age, and as I said you that the child wants the examination but the parents they don't want. Again, sometimes the parents they are guilty or they themselves are the criminal with some girls. So definitely the parent will never give you consent for the examination, but that girl, she is interested in medical examination. So in such cases we have to examine that girl, because the consent of that boy or girl who are about 12 years of the age, that is more important than the consent of the parents. Now what if there is no lady doctor in the institution and a girl is brought for the medical treatment? Again, I told you that if at all the thing is related to only examination, then the lady doctor can do. But at all, if she is in need of the emergency management, then the male doctors can treat that girl. And not only can they can treat, but they have to treat that girl if at all needed. Then if patient tells you that she's 19 years old but you're not sure, then what to do? So please, in such cases, you must ask some or the other age proof to that patient, and then only deal the case. Because if something goes wrong, if she is telling you that her age is 19 and unfortunately if she comes to below 18 years of the age, then you are again guilty and you will be punished. And it is your duty to prove that she was above 19 years of the age. And definitely that can be done with a paper, especially the living certificate or Aadhaar card, any paper can do. Then mandatory reporting when you are only suspecting the child sexual abuse and you are not confirmed. Again, even if you are suspecting the child sexual abuse, for example, if a girl is brought to your OPD and she is having history of some injury to the genitals, and you are suspecting that there is something fishy, then you have to, according to the POCSO Act, you have to inform to the police even if you are not confirmed, isn't it? Intention, then definitely the person will be punishable. So information to the police department is mandatory in such cases. Now what if the patient is very close to me? How can I inform to the police? Definitely patient gaya to chalta, पर आपकी खुद की कुछ उम्र पुलिस स्टेशन के behind the bars गए तो बिल्कुल नहीं चलने वाला. So definitely go and inform to the police. Don't worry, बहुत सारे patient उसके बाद में भी मिल जाएंगे. Friends, you know RKSK and some relation with the RKSK and POCSO, जहाँ पे कभी-कभी बहुत confusion होता है. What government says in RKSK, that is राष्ट्रीय किशोर स्वास्थ्य कार्यक्रम. Government, it is the training module for the ANMs and LHV. ये आप देख सकते हैं यहाँ पे कि handout number 8, it is contraception for the adolescent. Means government एक तरह हमको बोल रही है कि आप बच्चों को contraceptions के बारे में सिखाओ. Isn't it a indirect consent from our side for the sexual involvement? Definitely it is. और एक तरफ गवर्नमेंट सेक्सुअली इन्वॉल्व नहीं होगा 18 के पहले, इवन दो they are having asking us to give the knowledge of contraception to the everybody who is below 18 years of the age. And एक तरफ POCSO Act से हमें ये बोला जाता है कि no boys or girls they can be indulged in the sexual activity. So to conclude my words regarding the POCSO specifically, the POCSO Act is gender neutral. It is equally for the boys as well as girls. The abetment, that is to provoke somebody else or to attempt, both are punishable. Then reporting is absolutely mandatory, not only with the knowledge, but even if you are having apprehension, then there is penalty for the defaulters who are defaulting in the reporting. Then there are small changes in the examination and treatment to the victim if we compare it with the rape. Then there are some controversies and difficult situations which we have already discussed, and definitely there is a need of awareness in the public, not to the doctors but even the public, because sometimes if the girl, even if the married lady is coming to you below the 18 years of the age, even she is married and she is coming to your clinic for MTP or for the delivery, the public should be aware that doctor has to inform to the police, and if they are not aware, then they can create a lot of problems with you. Now these are some of the record tips. ये कहीं लिखी नहीं है, ये मैं मेरी तरफ से आपको suggestions दे रहा हूँ. Ask for the legal age proof in every unmarried pregnancy. Even if she is 20, 25, 26, जो भी हो, उसका legal age proof मांगना बहुत अच्छा रहेगा आपके लिए. It is not written in the book, but you have, if you are asking age proof, then it is always in your favor. And while advising the ultrasonography to any unmarried patient, don't write the probable diagnosis as pregnancy. फॉर एग्जाम्पल, रेखा मैडम के पास में मैंने सोनोग्राफी के लिए एक पेशेंट भेजा है, वो 18 साल के नीचे की है, और मैंने उसमें क्वेरी डायग्नोसिस मतलब प्रेगनेंसी लिखा, तो डेफिनेटली ये प्रूव हो गया कि आई वाज हैविंग द नॉलेज ऑफ हर इन्वॉल्वमेंट इन द सेक्सुअल एक्टिविटी. फिर वो गर्ल रेखा मैडम के यहाँ पे गई, उसने सोनोग्राफी किया और वहां से भाग गई कहीं और उसने कहीं और जाके अबॉर्शन किया, जो कुछ भी किया, और केस कोर्ट में आ गई. तो जब मेरा पेपर वहां पे जाएगा, सोनोग्राफी का पेपर जाएगा, और उसमें लिखा रहेगा रेखा मैडम ने कि शी इज प्रेग्नेंट और खाली रेफरिंग डॉक्टर गिरीश माने, इसका मतलब है कि डॉक्टर गिरीश माने वाज अवेयर ऑफ द फैक्ट एंड ही हैज नॉट इन्फॉर्म टू द पुलिस, तो डेफिनेटली मेरे ऊपर केस आ सकता है. सो इट इज ऑलवेज गुड टू राइट प्रोबेबल डायग्नोसिस एज लंप इन एब्डोमेन और व्हाटएवर यू कैन राइट, बट डोंट राइट the probable diagnosis as pregnancy. This is not written in the book, it is my personal experience. Then while doing USG of every unmarried patient, for any reason, ask for the age proof. For example, you are doing sonography for some other reason, for example, heavy bleeding or amenorrhea or lump in abdomen, and unfortunately, usko agar pregnancy nikli, तो you can be in trouble, and that's why uska age proof lena bahut zaruri hai aapke liye. Then while doing the delivery of married lady with the this conceptional age below 18 years of the age, अभी ये बहुत अनलॉफुल है जो मैं आपको बता रहा हूं, बट आपको करना है कि अगर ऐसी पेशेंट आपके पास आती है तो उसका एज उसने 18 बताया तो भी आप 19 लिखिए, एंड आस्क दैट लेडी टू फिल द एडमिशन फॉर्म इन हर ओन हैंडराइटिंग. उसको उसका नाम लिखने को लगाना, उसका एड्रेस लिखने को लगाना, एंड आस्क हर टू राइट हर एज एज 19, बिकॉज एटलीस्ट इस सिचुएशन में हम इतना तो बोल सकते कि उसने ही उसका एज 19 बताया, एंड कोई भी लॉ के अंदर में ये लिखा नहीं है कि डॉक्टर हैव टू टेक द एज प्रूफ. Whatever suggestions I am giving, they are just to save yourself, and that's why if at all possible, अगर उसका एज प्रूफ मांग लीजिए, और अगर उसके पास में एज प्रूफ नहीं है और अगर वो मैरिड है, सब कुछ अच्छा होने वाला है, तो डोंट राइट हर एज एज 18, जस्ट राइट पुट डाउन हर एज एज 19 एंड आस्क हर टू राइट द नेम, द एडमिशन, द डिटेल्स ऑफ द एडमिशन इन शॉर्ट टिल द उसका एज. तो अगर वो 19 लिखा तो दैट कैन बी लिटिल बिट helpful to you. Then educate your all doctor friends, for example, the pediatrician, the surgeons, the sonologists, then even pathologists who are giving the reports of UPT, isn't it? They should know this law. Then make a separate file for all the FIR and try to preserve it forever, क्योंकि ये cases 15 साल के बाद में भी निकल सकते हैं. Then inform police every pregnancy in your OPD if they are below 18 years of the age. So this is all about POCSO, what I can tell you. Now coming to the MTP. Everybody knows that no consent of guardian is required for the MTP if the patient is above 18 years of the age. But if she is below 18 years of the age, then the consent of the guardian, either parent or any other person who she is bringing as a guardian, should be taken. Then all other laws, they are same what they are for the adult ones. Then you have to inform to the SGPU or to the local police if that girl, she is below the 18 years of the age. And now coming to the product of conception, friends, whenever you are informing to the police regarding the involvement of that girl in the sexual activity, it is not mandatory on your part to inform that you are doing MTP, and police cannot give you the permission for the MTP. MTP is your right and the right of that girl. The only thing you have to inform to the police, take the consent of the parents and go for MTP. And as soon as you finish the MTP, you have to send one letter to the police department for the collection of the POCs, because that is the evidence to prove the involvement of that person who was indulged or by doing the DNA profiling and all. And you have to preserve these POCs in the normal saline, keep it in the refrigerator, and within 72 hours of your information, police have to carry those product of conception, because after 72 hours they are not of any use. And if you are not informing to the police, तो आपके ऊपर में आपने सबूत मिटाने का जुर्म लग सकता है. So definitely it is our duty to preserve the POCs and to inform to the police. And you should inform to the police immediately as soon as you finish up your MTP. और उसके ऊपर में पुलिस का सिग्नेचर भी लेना और उनसे डेट एंड टाइम भी लिखवाना. एंड अगर हम लोग ये नहीं करते हैं तो हमारे ऊपर में नया केस लग सकता है. So to conclude my talk, some take-home messages for everyone that ignorance of the law can never be an excuse. ये गवर्नमेंट की नहीं है, हमारी ड्यूटी है कि सारे लॉज हम जान ले. It is our duty to know the laws. Then to follow the laws is always beneficial, not for the doctors, for everyone. कभी भी law हमारे लिए तकलीफ वाले नहीं होते हैं. Then to inform to the police is mandatory according to the POCSO Act. And if the police department is not cooperating you for putting the FIR or any other thing, then remember this number 1089 and directly give one call on 1089. And if you are not remembering this number, then you can call on 100. For example, in Maharashtra, the call will be directly go to Mumbai, and from Mumbai, the action will be taken to the Department of Police Department from my place, and definitely the things will be, the things will go on. Then spread this knowledge of POCSO Act and all other act to all your medico friends, especially the pathologists, sonologists, surgeons, and pediatricians who are dealing with such kind of cases. And there is no need to take the permission from the police for MTP, and you have to preserve the POCs in normal saline at least for 72 hours after doing the MTP. And the last, please keep inviting me in future. I'll be definitely happy to attain any physical CME in the Bhagalpur along with Basab sir. Thank you very much.
Thank you.
Thank you, Dr. Girish. It was really excellent. And you have given, and you have rather warned all of us, we medical practitioners, must know what we are doing and what we are not doing. We are doing many things, but we are not doing many things as well. We are not informing the police. We are doing MTPs. So all these things must be streamlined. And before that, I forget, I would like to hear from you about the extension of age for MTP, not talking about the age-related one as such. It has been
extended. There are some, yes, ma'am, there are some newer amendments. For example, initially we used to take signatures of two special doctors about 12 years for the MTP, about 12 weeks. But now the signature of a single doctor is okay till 20 weeks. Number one. Number two, we can do MTP up to 24 weeks of gestation, but the indications are different. For example, we can do it for congenital abnormality. We can do for the change of the marital status of that lady. For example, if she's widow or if she's unmarried, then we can do that MTP. Then we can do MTP if there is some national disaster. For example, some disaster conditions are there, then definitely we can do MTP. I mean, there are some few indications where we can do MTP between 20 to 24. And the last and important thing, we can do
signature of how many doctors? One only or two?
Madam, signatures of two doctors is 101% required for the MTP between 20 to 24. And if it is below 20, then the signature of only single doctor is
that's okay. That's okay.
And we can do MTP even after about 24 weeks of gestation, but you have to apply to the medical board, which consists of one pediatrician, one gynecologist, and some NGOs. These are nominated by the appropriate authority of that place. And if the medical board is giving you permission for the abortion, then we can go. And the things are only applicable to the grievous congenital abnormalities. And we cannot apply and we cannot do MTP for any other reason about 24 weeks.
Right. He has Dr. Girish has spoke so well, but you know how much we have digested. I ask myself sometimes, I'm telling you why, you know, Dr. Girish.
Yes, ma'am.
A couple of years ago, I think more than 6 or 7 years, there was a young talent promotion conference which was held in Patna, and it was organized by currently our president, Dr. Vinita Singh.
And I was there, madam,
She told me, प्रमिला दी आपको ऑर्गेनाइज करना है. हम बोले ठीक है, क्या करना है? तो बोला उसने कि पॉक्सो पे. I never heard of पॉक्सो by that time. I didn't know anything. I said, विनीता ये क्या है भाई, हम तो नहीं जानते हैं. ठीक है, चलो, take it as a challenge and we'll read it and we'll do it. And believe me, पॉक्सो के बारे में जितना हो सकता था मैंने खुद पढ़ा, बहुत समय उसके ऊपर दिया, पढ़ा, लोगों को बताया. And we had a public forum on POCSO involving our other non-doctors, the associations like Rotary, women cells, all those things. And it was and luckily I could get a book which is written in Hindi on POXO by one lady IAS officer, Vijay Lakshmi. Her name was Vijay Lakshmi. मुझे गॉड गिवन मुझे वो किसी का लिंक मिला, मैंने उनसे बात की, and she sent me about 250 copies of the books, and we distributed in that conference. And it was such a good thing. And I really tell you, POXO has to be learnt by ourselves, spread the POXO news to our friends, and also really practice it. And honestly telling you, I don't think much of the work is being done for POXO because of fear.
Correct. Madam, actually PCPNDT was developed so many years ago, but the people, especially the doctors, they were not following it very seriously. And जब law के public को पता चला, तो उन्होंने जो हवा किया, उसके बाद में बहुत सारे लोगों ने भुगता. Right now we are on the same path. अभी तक पुलिस डिपार्टमेंट एंड बाकी लोगों को ये मालूम नहीं करके कोई हमारे पीछे नहीं लगा, लेकिन जब इन लोगों को पता चलेगा तो सभी डॉक्टर्स को वो बाद में भी ट्रबल में ला सकते हैं. इसलिए द बेस्टेस्ट पॉलिसी कि हम आज से ही हमारे प्रैक्टिस में उसको अप्लाई करें.
Yeah, very true. Really very true.
And as you said rightly, only lady doctor can examine the girl victim. So lady doctor can examine the boy victim as well?
Yes, ma'am. Yes.
Okay. And Anju, would you like to just conclude, as he has rightly very nicely
Okay, ma'am.
And any questions, if any? Time, please keep to the time. I don't know what is the limit.
Okay, thank you, ma'am. Nothing much, you've already said everything. Nothing much to say. Only I can thank him for enriching our knowledge with all what he said and everything. Moreover, thanks for participating here. It was a wonderful occasion to share this with you.
Thank you, ma'am. My pleasure.
Thank you, ma'am. Pranam, ma'am.
Pranam.
So, thank you.
Co-chair with you is quite a good thing.
Any questions?
Last but not the least, I would give all the best for Pratibha and Supriya for the coming elections.
Thank you.
All the best.
Thank you. Thank you.
Thank you very much.
So we had a very important legal issue related to adolescent age. And there are so many laws, but POXO, which is very important for us to understand, and very rightly said by Dr. Mane, that this is the law which can put we gynecologists behind the bar. So ignorance of law can never be an excuse. That is very important. That should be the bottom line. So such an excellent and eye-opener talk. Thank you so much, Dr. Girish Mane, for such wonderful talk and coming to Bhagalpur and accepting our invitation and sparing your valuable time and knowledge with us. And I also want to thank our chairpersons, Dr. Pramila Modi Madam and Dr. Anju Toriyar, for their valuable inputs. Thank you so much.
Thank you.
Thank you, all of you.
Thank you.
Thank you, Dr. Girish.
So now we move on to our next talk. And as we know, the adolescent age is a very vulnerable age where they undergo many emotional and physical changes. And for young girls, they have a very frequent problem, that is a menstrual problem, which can be a irregular period or abnormal or heavy or prolonged bleeding, which is usually assessed due to immature hypothalamo-pituitary axis. And for that, we have a brilliant speaker today, our own President, Bhagalpur Obs and Gynae Society, Dr. Rekha Jha Madam. But before she starts her talk, I must introduce our chairpersons. So our first chairperson is Dr. Rajni Sharma Madam, again from Patna. She is the life member of FOXY, and she is presently the chairperson of HIV and AIDS Committee, POGS, Patna. And she held various posts in Patna OBGYN Society and was chairperson for various committees in Patna Society. And at present, she is the professor and the unit head for the Department of Obs and Gynae in Patna Medical College, Patna. And she is also the master trainer for AMOC and BMOC. And she has a vast teaching experience for more than 30 years. And she is also the undergraduate and postgraduate examiner for different universities. She has been a life member for so many societies and associations, right from FOXY to ISOPOW. And she has many publications to her credit and many booklets. So with these words, I will welcome Dr. Rajni Sharma Madam to this forum. Now our next chairperson is again a very promising, upcoming and most trusted Foxian, Dr. Priyankur Roy. And here I must acknowledge his dedication and sincerity towards the organization. And I welcome Dr. Priyankur, and it's my proud privilege to introduce you. Always you are introducing me today, always, and this time today it's my honor to introduce you. He is the assistant professor in Lord Buddha Kosi Medical College Hospital, Saharsa. He's a consultant in fertility and gynec endoscopic surgeon in Roy Clinic and Nova IVF Siliguri. He's a joint secretary of Siliguri Obs-Gynae Society and IMA Siliguri chapter. And he was a very successful organizing secretary for the East Zone Yuva Foxy, which was held last year, 2020. He has more than 70 articles to his credit, authored more than 20 chapters. He is a peer reviewer of many journals and presented more than 50 articles in the conferences. And he is a recipient of many awards, and to name few, Korean Award Junior category in 2017, then Dr. Kamini Rao Orator in 2020, and greatest Dr. Kumud Tamaskar Research Award in 2021. So with this, we have high hope from him, and I know he has a great future ahead. And so keep doing good work and all the best for your future endeavors. And he is an aspirant candidate for the chairperson for the Public Awareness Committee. So all the best to you, Dr. Priyankur. And with this, I hand over the session to our chairpersons. So over to you. Now, Dr. Priyankur.
Thank you so much, Pratibha ma'am, for the wonderful words and for the introduction, ma'am. Thank you so much. Respected Rekha Jha ma'am and Dr. Kavita Banwal ma'am, I sincerely thank both of you for giving me an opportunity. And of course, it's been a pleasure to share the dais today with the chief guest, Dr. Alka Kriplani ma'am, and the guest of honor, Dr. Basab Mukherjee, and of course, our chairperson of the Adolescent Health Committee, Dr. Girish Mane sir. It's always a pleasure listening to his talks, to his songs, and to whatever he does. He's such a fun man. Thank you so much, Girish sir, for the wonderful talk that you have already given. So now it gives me pleasure in welcoming our speaker, Dr. Rekha Jha ma'am, who's a wonderful speaker, currently the president of the Bhagalpur OBGYN Society. She is a very active member of a public awareness committee, and she is a consultant gynecologist practicing in Bhagalpur. Ma'am has held various posts in the Bhagalpur OBGYN Society, and she has also been the vice president of the IMA Bhagalpur chapter. She is a patron of the Jivan Jyoti Society of Bhagalpur. With a lot of pleasure, I hand over the platform to Dr. Rekha Jha ma'am for a talk on adolescent AUB.
So thank you, Priyankur. You have spoken very well of me. I find myself very small in front of such dignitaries, but with my little abilities, I will try to do some justice to the topic. Okay, so I'll share my slide now. Can it be seen?
Yes, madam.
Okay. So the topic today, which I am speaking, is abnormal uterine bleeding in adolescents. The prevalence of abnormal uterine bleeding in adolescents are about 40 to 50%. So about 40% and 55.7% by some textbooks. Out of those who have AUB, 20% have bleeding disorders. Von Willebrand's disease, 5 to 36%, platelet function defects, 2 to 44%, thrombocytopenia, 13 to 20%, and clotting factor deficiency in the rest of the 8 to 9%. So the patients who come over in the clinics, most of the adolescents have this disorder because it is 40 to 55%, in which there are no bleeding disorders. So we have to deal with such patients who do not really have any bleeding disorder defects, but something hormonal, some hypothalamic pituitary ovarian axis problem. So the menstrual pattern which is seen is in menarche, normal menstrual cycles in young girls in menarche is 12.43 year. Mean cycle interval is 32 days and the menstrual cycle interval is typically 21 to 45 days. The menstrual flow length is 5 to 7 days and menstrual product use is about 3 to 6 pads or tampons per day. So this is the normal menstrual cycle. And for patients reporting with heavy menstrual bleeding, they will say that it soaks in 1 hour for 2 to 3 hours in a row. That is, one tampon goes away in 1 hour. And this happens for every consecutive hour. They are passing blood clots greater than 1 inch in diameter and using double protection, that is tampons and pads together, they can feel the flooding or gushing sensation and frequent accidents of leaking through the protection, that is smearing the clothes, and many diagnosed with anemia. So the patient presentation is that कि हर घंटे में जो है पैड सोक हो जाता है, तो 3 घंटे ऐसा लगातार चलता है और बड़ा बड़ा थक्का निकलता है एंड 2-2 पैड लेने पर भी सॉइलिंग हो जाता है, कपड़ा भीग जाता है और चेहरा ही पेल लगता है, मतलब एकदम एनीमिक दिखती है पेशेंट. Causes of abnormal uterine bleeding in adolescents. The list is endocrinologic, dysfunctional uterine bleeding, immaturity of the hypothalamic pituitary axis, polycystic ovary syndrome, and thyroid disturbances. So these are the endocrinologic factors. Causes hematologic, von Willebrand's disease, platelet function disorder, connective tissue disorder, thrombocytopenia, hemophilia carrier, clotting factor deficiency. So at the back of the mind, even though we know most of the cases are endocrinologic, we have to keep at the back of the mind that it can be a hematologic disorder. Then again, pregnancy complications may be there. Though they are adolescents, pregnancy may be there. As we have already heard from the previous speaker, Dr. Girish, that many a times they come with pregnancy and maybe they have taken some abortion pill or something. So that should be also in mind. Sexually transmitted infections, pelvic inflammatory disease, and medications like hormonal contraceptives, antidepressants, platelet inhibitors, anticoagulants, or any type of trauma, any systemic illness. All these should be in our mind while talking to the patient. Abnormal uterine bleeding, the most common cause of AUB in adolescents is anovulation, secondary to a disturbance of the normal hypothalamic pituitary ovarian axis. ACOG considers AUB synonymous with anovulatory uterine bleeding. Others are blood dyscrasias, hypothyroidism, PCOD, genital tuberculosis, liver disorders. एक बार में दिमाग में फ्लैश होना चाहिए कि कहीं ये ब्लड डिस्क्रेसिया तो नहीं है, हाइपोथायरॉइडिज्म तो नहीं है, पीसीओडी, जेनाइटल ट्यूबरकुलोसिस और लिवर डिसऑर्डर, कुछ भी हो सकता है. इनफैक्ट मोस्ट ऑफ द केसेस में नहीं होता है, लेकिन कुछ भी हो सकता है. ऐसा सोच करके ही चलना चाहिए. I can't move the slide. Yes. So physiology and ovulation, immaturity of the hypothalamic pituitary ovarian axis, the most common cause of abnormal uterine bleeding in adolescents. The first post-menarchal year, 50% are anovulatory. That means जैसे ही menarche होता है, menses start होता है, तो 1 साल तक तो HPO axis एकदम ही इस तरह behave करता है कि heavy bleeding या irregular bleeding या कुछ हो सकता है. And this all depends upon the age of menarche. If it is less than 12 years, then the duration of ovulatory cycles will be attained in a year. But as more and more age of menarche increases, like if it is 12 or 13 years, तो 3 years तक जो है ovulatory cycles establish होने में लगेगा. So at lesser age, the establishment of cycles are better in 1 year. And if the menarche age is 12 to 13 or greater than 13, it may take 3 or 4.5 years too. So इस तरह से ध्यान में रखना है कि age of menarche is important so that we can counsel कि 1 साल में खत्म होगा, 2 साल में खत्म होगा या 3 साल में खत्म होगा. Without ovulation, there is no progesterone from the corpus luteum after ovulation. The endometrium has unopposed estrogen and will thicken until it must slough. Endometrium becomes excessively vascular without stromal support, fragile and irregular endometrial bleeding. The pathogenesis. So the vasodilators versus vasoconstrictors. The vasodilators means antiplatelet aggregators, less of progesterone, fibrinolytics, less of endothelins. The mediators are prostaglandin E2 and prostaglandin E1 and TPA, tissue plasminogen activator. And the vasoconstrictors, more of progesterone and more of endothelins. The mediator is PGF2 alpha. So hypoestrogenism, hyperplasia, and ovulation and abnormal endometrial hemostasis results in menorrhagia. When we go for further evaluation, so keep in mind structural causes, PCOS, thyroid disturbances, pregnancy, bleeding disorder, medication, systemic illness, and trauma. Lab evaluation, the blood profile, hemoglobin, BTCT, coagulation profile, and blood film. X-ray chest for tuberculosis, thyroid tests, and serum prolactin, pelvic ultrasound for PCOS and ovarian tumor or uterine fibroids. Sometimes, if medical treatment fails, and DNC to rule out endometrial tuberculosis. We have to know the pregnancy status and beta HCG test. We have to keep in mind about abortion, ectopic, or molar pregnancy. So accordingly, the beta HCG will show whether it is abortion or molar, and transvaginal sonography if pregnancy is suspected, to be more sure about the size of pregnancy and what type of pregnancy, whether it is a missed abortion or something like that, if she has taken something. So whom to screen for bleeding disorders? High sensitivity for the presence of bleeding disorder when any of the following are present. Bleeding disorder के बारे में सोचना कब है? Duration of menses are more than 7 days with flooding or impairment of daily activities with most periods. History of treatment for anemia. बार बार anemia के लिए दवाइयाँ लेती है, 7 दिन से ज़्यादा को bleeding होता है. Family history of a diagnosed bleeding disorder, excessive bleeding with tooth extraction, surgery, or any childbirth or miscarriage. So the history will elicit whether we have to screen for bleeding disorders or no. Suggested approach to evaluation of bleeding disorders. The first line is CBC, PBC, APTT, PTTT, fibrinogen, ferritin, renal, liver function test, TSH, and von Willebrand's factor. Second line, repeated von Willebrand's factor, platelet function testing. And third line is factor assays, all the clotting factors, and further sub-specialized testing should be directed by clinical picture. So the testing should be done in consultation with a hematologist. That is important because if we are suspecting, if there is a history of family, history of some bleeding disorder, be in line with a hematologist for proper diagnosis. Clinical classification is mild, moderate, and severe. Mild is greater than 7 days for 2 months, flow mild to moderate, and hemoglobin 10 to 12. Moderate when greater than 7 days, flow is moderate to heavy, and hemoglobin is just above 10. And severe is disruptive bleeding, heavy bleeding, and hemoglobin goes below 10. Goals of management, establishment and or maintenance of hemodynamic stability, correction of acute or chronic anemia, and return to the pattern of normal menstrual cycles, prevention of recurrence, prevention of long consequences of an ovulation. So what we have to treat is the anemia. The cycles should become regular and no recurrence should happen so that the patient is comfortable and so that anemia is not repeated and hemodynamic stability is maintained. Prevention of long-term consequences of an ovulation, that is also we have to treat because that may lead to quite a severe anemia and in a long-term infertility and endometrial cancer. So management, the management This is the management we should start off with. Tranexamic acid to decrease the fibrinolysis by inhibiting tissue plasminogen activator. Estrogen 25 mg 6 to 8 hourly in severe cases to control the bleeding. Primarine. Thereafter, estrogen 21 days, progesterone for the last 10 days. NSAIDs, mefenamic acid, 250 to 500 into 3 times according to the body weight. Naproxen, Ponstan, ibuprofen, any of these can be used. Anti-tuberculous treatment if there is endometrial tuberculosis, and role of androgens, danazol, it is not very good. GnRH takes 4 weeks to have its effect. Marina may be used at times. Arterial embolization only if there is intrauterine varicosity, and tamponade when all other things fail. There is role of blood transfusion according to the case if the patient is very anemic, and vasopressin IV or nasal spray 1.5 mg per ml, total 150 to 300 milligram in von Willebrand's disease. Now, correction of anemia for girls with mild or moderate bleeding and asymptomatic anemia, initiate iron supplementation with 60 mg elemental iron per day. For girls with severe AUB, initiate iron supplementation as soon as the patient is stable and able to take pills by mouth. Depending upon the severity of iron deficiency, use 60 mg of elemental iron once or twice per day. So either it is mild, moderate, or severe, anyway, 60 mg elemental iron has to be started. It can be given once or it can be given twice in severe cases. And then for severe cases, hormone therapy. Rationale of hormone therapy. Administration of exogenous estrogen permits additional endometrial proliferation, which heals the sites of endometrial bleeding and provides hemostasis. Administration of progestin stabilizes the endometrial lining. The concern is high doses of estrogen may cause premature closure of growth plates, reducing ultimate adult height. However, by the time of menarche, most female adolescents have already undergone their growth spurt and achieved approximately greater than 95% of adult height. So not very difficult to give these hormones because most of them have achieved the adult height. So we can give, and moreover, it is temporary only. So monitoring of the response, adolescents who are being treated for anovulatory uterine bleeding should maintain a menstrual calendar to monitor response to therapy and subsequent episodes of anovulatory uterine bleeding. ऐसा बताते हैं पेशेंट्स को कि नोट करके रखना कि कब ब्लीडिंग हुआ, किस डेट को और कितना हुआ. Several smartphone apps are available at no cost, and this may facilitate the recording. So mild bleeding, hemoglobin is normal, contraception no, treatment is observation and reassurance. So as I earlier said, that only when the hemoglobin dips down, then only we can start hormone. Otherwise, we can give only iron therapy and keep a menstrual calendar, follow up in 3 months unless the severe bleeding. Moderate outpatient settings, hormonal therapy to stabilize the endometrium. The hormonal therapy regimen depends upon whether or not the patient is currently bleeding, the dose of estrogen, dose and type of progestin, and schedule of administration vary widely. Monophasic OCP containing 30 to 35 mg ethinyl estradiol, preferred for most adolescents. Norgestrol 0.3 mg, ethinyl estradiol 30 mg, levonorgestrol 0.15 mg, and ethinyl estradiol 30 mg. Norgestimate and ethinyl estradiol combination, and regular daily use with monthly withdrawal beads or extended cycling. So these OCPs can be given, the monophasic ones, to control the bleeding, and different types are available. Progesterone therapy for adolescents in whom estrogen is contraindicated or poorly tolerated. Medroxyprogesterone 10 mg continuously for 10 to 12 days, and norethindrone acetate 5 to 10 milligram daily. So it can be either given continuously or only for a 10 to 12 day period. Tranexamic acid 1300 milligram 3 times a day for 5 days during menses, and treat for at least 6 months, then reassess the need for therapy if desired. So the treatment part is only iron, and then coming to the monophasic OCPs, and then going on to progesterone only pills. And this can be given for 3 months, and then reassessment should be done. And in between, when the bleeds are happening, then tranexamic acid is given. Actively bleeding, combined estrogen progestin oral contraceptive rather than progestin only hormone therapy, because estrogen will provide hemostasis. Monophasic oral contraceptives with a minimum of 30 mcg ethinyl estradiol to ensure a sufficient amount of estrogen to prevent the breakthrough bleeding. If bleeding recurs when the dose is decreased to once per day, twice per day, dosing may be necessary for the full 21 days. So it can be given, and sometimes 2 pills have to be given to prevent the breakthrough bleeding. Progestin only pills only when combined oral contraceptive contraindicated or is not tolerated. Progestin only regimens may be used to mature and slough the endometrium. For acute management, oral progestin is preferred to other progestins only. Micronized oral progesterone is preferred because it is chemically identical to endogenous progesterone. Now, this is the most important part, the counseling in such patients. That is the most important part. You have to instruct the patients to take oral micronized progesterone every night for the first 12 days of each calendar month, as this regimen seems the easiest for the teenagers to follow. Whatever pills we are giving, we have to tutor them, रटवा देना है कि कब खाना है और कैसे खाना है. It is not a method of contraception. We have to explain that. If they become sexually active and desire contraception, they will need combined oral contraceptive pills. If they have unprotected sexual activity while using progesterone therapy, then emergency contraception has to be given. These things have to be explained to, they should be told कि ऐसा कुछ होना नहीं चाहिए, and it should be taken very diligently. Severe bleeding. Now, this is a thing which happens, and we are really alarmed when hospitalization is required for such patients. If there is hemodynamic instability, if the hemoglobin concentration is less than 7, home management with daily monitoring may be possible for patients with hemoglobin between 8 and 10. If the patient is hemodynamically stable and the patient and family are reliable and can maintain close telephonic contact. Because what happens? If it is between 8 and 10, it is okay. But suddenly, if there is a bleed and it goes below 7, it becomes alarming. So they have to be very reliable and tell the doctor at the correct time so that the patient can be admitted. Symptomatic anemia. If there is symptomatic anemia, then also we should suspect that there is heavy bleeding. Need for intravenous conjugated estrogen. Example, if she cannot take oral medications, continued heavy bleeding after 24 hours of estrogen-progestin combination therapy or surgical intervention. सब कुछ हो गया, दवाइयां दे दी, DNC भी हो गया, फिर भी bleeding हो रहा है, then you have to admit for intravenous conjugated estrogen, and then there is a need for surgical intervention. Important to evaluate for bleeding disorders. Blood for evaluation of bleeding disorders should be obtained before administration of blood products or estrogen. This is important. पहले patient का blood लेके उसका sample भेज देना है for testing before giving estrogen. It may elevate Van Willebrand's into the vaginal. This I don't understand, so I will not elaborate. So involve a hematologist. But can anybody tell me what it is in between? Exogenous estrogen may elevate the von Willebrand's factor into the normal range. So there may be the diagnosis of von Willebrand's may be missed. So we should take the blood sample first. So lowered hormone therapy, lower doses of estrogen, example 30 or 35 mcg ethinyl estradiol, one pill every 4 to 6 hours until the bleeding subsides. One pill every 8 hours for 3 days. Then one pill every 12 hours for up to 2 weeks. Anti-emetic treatment may be required for girls who are taking more than one pill per day. दवाइयां लेते ही vomiting होता है. That is why you need to give the anti-emetic therapy also. So one pill every 4 to 6 hours until the bleeding subsides. One pill every 8 hours for 3 days, and then one pill every 12 hours for up to 2 weeks. Parenteral estrogen reserved for patients with severe anovulatory uterine bleeding who are unstable and cannot take oral medications. If the bleeding is not controlled after 24 hours or combination hormone therapy. This is reserved for such cases. Practical tips, the dose of IV conjugated estrogen is 25 mg every 4 to 6 hours until the bleeding stops. No more than 6 doses should be administered. Thromboembolism is a potential complication. Administration of antiemetics 1 hour before each dose of IV estrogen may alleviate the side effects of nausea and vomiting. So when IV conjugated estrogen is being given, keep in mind about thromboembolism, and just an hour before giving the dose, give some antiemetic so that there is no nausea and vomiting, or it can be controlled. Bleeding usually subsides within 4 to 24 hours of initiation of IV estrogen. Hemostatic therapy. So 24 hours unko patients rakhna hai so that the bleeding subsides. Hemostatic therapy may be warranted if bleeding persists beyond 24 hours. If bleeding lasts longer than 24 to 48 hours after initiation of IV estrogen, oral progesterone should be added to stabilize the endometrium. Oral progesterone should be discontinued when oral contraceptive pills are initiated. After the bleeding subsides, the patient should be switched to a taper of combination of monophasic oral contraceptive. So bleeding subside hone ke liye wait karna hai after giving IV estrogen 4 to 24 hours, and even if that doesn't happen, then add progesterone orally, and when it stops, then switching over to oral contraceptive pills, and then progesterone should be stopped because it is monophasic. Okay. Intravenous estrogen is not available these days. So may I know who has written that, because I don't know the identity. Anyway, hemostatic treatment. Tranexamic acid is. It was
Poonam.
Kavita?
No, Poonam.
Poonam. Okay. Thank you, Poonam. Okay. Tranexamic acid. Actually, we will talk later on. Hemostatic treatment. Tranexamic acid is administered orally, 1300 milligram 3 times per day for up to 5 days with each menses. Aminocaproic acid may be administered orally or IV. Desmopressin is administered IV as follows. Maintenance, oral hormone regimes, LNG, IUS, DIMPA, Norplams. Oral regimes and follow-up maintenance. This is self-explanatory. Hemoglobin less than 10. Monophasic combined OCP for 3 months. Combined oral contraceptive for 21/7 for another 3 to 6 months. If hemoglobin is greater than 10, combined oral contraceptive for 21/7 for another 3 to 6 months, and discontinue after 6 months. Monitor the hemoglobin always. Changing the standard regimen, shorten the hormone-free interval from 7 days to 3 to 5 days to provide greater ovarian suppression and decrease the incidence severity of hormone withdrawal symptoms. Extend the days of active OCs to greater than 21 days. Add estrogen during the hormone-free interval. Cyclic 21/7 or 24/4, extended 6 weeks on 4 days off and continuous. So these are the regimes, either cyclically or 6 weeks on and 4 days off, or continuously giving the pills. Vaginal ring can also be used in continuous fashion. treatment of mild, moderate, and severe. We have already talked about it. So thank you for the patient here listening.
Thank you, madam. Then over to our chairperson, Dr. Rajni, madam.
As a chairperson, I thanks Dr. Rekha Jha, President, Bhagalpur Obs and Gynec Society, for an excellent and insightful talk on adolescent AUB. AUB is a common presenting problem for adolescents. It is a most often due to anovulatory cycle resulting from immature hypothalamus, pituitary, and ovarian axis. Generally, it takes 18 months to 2 years for regular cycle to be established. Other causes of adolescent AUB are PCOD, about 14% cases, genital TB, hypothyroidism, adrenal hyperplasia, congenital adrenal hyperplasia, blush dyskeriosis, and feminizing ovarian tumor like granulosa cell tumor and theca cell tumor. Apart from treating the cause, our primary aim is to control menorrhagia, treat anemia, and prevent reoccurrence. In some cases of AUB, according to Dr. Rekha Jha, sometimes arterial embolization is also will be needed. For varicosity, treat varicosity of uterine vessel, and sometimes when bleeding not controlled in acute episodes, uterine tampon using Foley's catheter for 24 hours control bleeding in these cases. So very good informative talk by Dr. Rekha Jha. Now, I thank the organizer for organizing such a informative webinars. As a special thanks to Dr. Kavita Barnwal for giving me opportunity to chair this session. Thanks, Pratibha.
Thank you. Thank you, madam, for your valuable inputs. And we have Dr. Girish Mane also with us. So I'll take some input from him also.
Hello.
Yes, sir.
I think Madam Rekha Madam has covered everything. And Madam, your talk was absolutely crisp and lovely. और आपने बोला कि मैं लिटिल एबिलिटीज के साथ में ये करूंगी, लेकिन आपने तो अच्छे से भी मतलब काफी चौके छक्के लगाए हैं, और हम ये बिल्कुल ही मान नहीं सकते कि आपने मतलब जो भी कहा है वो आपका सेंटेंस हम बिल्कुल नहीं करेंगे.
She is an excellent speaker, sir.
Yes, I know. Anyway, I just want to put only one thing, that any girl who is having blood dyscrasias, usually she will have the history of AUB since her menarche. I mean, usually 90% of the girls, or most of the girls, they are having history of oligomenorrhea, or I mean little less bleeding in their menarche. But such kind of girls, I mean, who are the patients of von Wall disease or any blood dyscrasias, they will definitely have the history of prolonged and excessive bleeding in their very first menses, number one. Number two, whenever the girl is pre-diagnosed as having the blood dyscrasias, for example, because of the history of tooth extraction or any other surgery or family history, then the proper counseling of such kind of girls and their parents is very essential. They should have all the equipment. For example, she should have the pads, and she should have the knowledge that she's going to bleed more as compared to her friends. And that's why the counseling, the proper judgment of the girls and the proper counseling of such kind of girls, it is very important. Counseling of the girls as well as the counseling of the parents. Wherever you are suspecting the blood dyscrasias in any girl without their this menarche, before their menarche.
Thank you. Thank you, Dr. Girish. Dr. Girish.
Thank you, everybody.
Thank you.
Everybody for your compliments, but truthfully, I have been out of the practice of speaking for many, many years.
But you did well.
So excellent talk,
very well,
madam.
Rekha, madam.
Excellent
Spoken
talk.
very well.
And as it is said that AUB is an adolescent girl may be acceptable at the beginning with menstrual cycle irregularities, which is not established, or it may be the sign of severe underlying bleeding disorder, which is very rightly said by Dr. Girish Mane also. So we have to be careful, and we should evaluate and assess the case properly, and then you should manage it. So thank you so much, madam, for such elaborate and informative talk today. And I also want to thank our chairpersons, Dr. Rajni Sharma, madam, and Dr. Priyankur Roy for their valuable input. Now we move on to our next session, which is again another entity for adolescent females, and that is PCOS, which is the most common endocrine disorder in the women. And there is a lot of controversy continues about underlying etiopathogenesis, diagnostic criteria, and recommendations for PCOS in adolescent girls. So we have an interesting panel on this topic, and where we have quite experienced moderators and expert and a very knowledgeable panelist. So I welcome all of you. And now it's my proud privilege to introduce our first moderator, our guest, Dr. Charmila A. Ayavu, a great friend of mine, a very hardworking, a dedicated Foxian, and she is the chairperson. She is the ICOG Governing Council member 21-23, and she was the chairperson Clinical Research Committee Foxy in 2016 to 18, National Coordinator UNICEF Foxy PCA, National Coordinator of a very famous Medha Foxy PG program, WHO Serum MDSR India member 2021, past secretary Trichy Ops Gynae Society, and she is also the joint secretary of Gestosis India Association and joint treasurer IFS Tamil Nadu. Somebody IFS Tamil Nadu chapter. And with this, we have another feather in her cap, which is going to be added now. That is the future Vice President Foxy. So all the best and congratulations, and welcome Dr. Charmila to Bhagalpur.
Thank you, Pratibha. Thank you so much.
And our next chairperson is again, we all know she is our own secretary, Bhagalpur Ops and Gynae Society.
I have been introduced, I have been introduced, moved to expert.
I know. You are a very hardworking and dedicated Foxian, so welcome. And with this, we have an expert with us, and she is our own Dr. Poonam Dikshit madam, our well-wisher from Patna. She is the consultant obstetrician and gynecologist and laparoscopic surgeon, Poonam Surgical and Maternity Hospital, Patna. She is a past fellow representative AICC RCOG Eastern Zone, and she also runs the Foxy Certified Ultrasound Trainer for basic and advanced courses. And she is also the member of past task for ISUOG, which is International Society of Obstetrics and Gynecology from 2018 to 21. Chairperson Imaging Committee FOX and the member Imaging Committee Foxy 2018 to 20. And she has a special interest in NDVH, education and training high risk pregnancies. So welcome, madam. And with this, I hand over the session to the moderator for further proceedings. Over to Dr.
Thank you, Pratibha.
Thank you.
Thank you, madam.
So can I see the CV of panelists? Yeah, we have 7 panelists. So firstly, Dr. Rajnaja, my own friend, consultant gynecologist, Katihar Seva Sadan, very active social worker, and has been awarded by for Surakshit Patrit Abhiyan, and her special interest is so much social work. She does social work. Secretary, Indian Red Cross, founder and present secretary of Katihar Ops Gynae Society, and formerly she was associated with MGA Medical College, Kishanganj. Next is Supriya Jaspal. She is very active secretary of Patna Ops Gynae Society, and she is also an aspiring candidate for this year. And she is a specialist at SM Hospital, Patna, communicator Central ISOPOP, East Zone Coordinator, Adolescent Health Committee, Foxy, Member Adolescent Health Committee Foxy, Executive Member Ishar, Bihar Chapter, Executive Member IG, Patna Chapter, and she has been awarded with many awards, and CJ has also hold the post of Joint Secretary, Clinical Secretary, Executive Committee Member, Treasurer of POX, and presently she is working as Secretary. And she was Joint Organizing Secretary of 24th BoxCon 2014 and 25th BoxCon 2016. Her special interest is high-risk pregnancy and preventive oncology. Next CV, yeah, Dr. Kiran Trivedi Sharma is Secretary of Ranchi Afghani Society, and she is also very active and hardworking member of life member of IMA, Foxy, ASOPAB, IFS, presented various papers in national as well as international conferences, member of PCP and DT State Supervisory Board, member of IC Foxy 2021, invited as external examiner in MBBS, PG as well as DNB courses, and faculty of SCOG. Next CV, yeah. Dr. Sipra is a professor in the Department of Afghani, Katihar Medical College, though her CV is very small, but she is very active, very hardworking, and I know her personally. She always likes to present the papers and goes to all the national as well as state conferences. Next CV, yeah. Dr. Prabhati Kesri is from our own society. She was past secretary of Bhagalpur Afghani Society, very active and has led our society to very new heights. And she is director at Sant Sharda Nursing Home Bhagalpur. Next. See, Dr. Komal Gupta is very junior, is PG student from JL NMCH, but very studious and academic. And I welcome all the panelists. And I request our moderator, chief moderator, Dr. Charmila Ayu madam, to conduct the first part.
Thank you, Dr. Kavita. Thank you so much.
As much as she can.
Thank you so much, Dr. Kavita. And I would like to thank Dr. Pratibha. All the best to you, Pratibha, such a hardworking person. You should get through for that hard work. And I'd like to thank Girish Mane as well as Dr. Rekha, did wonderful talks. There was so much of knowledge there. And the panel will be actually a very simple and practical discussion of adolescent PCOS, because we do the management of these girls at every level in our practice. And we need to be very clear about what we are going to do when you're going to manage a young girl who has been diagnosed as PCOS, because you cannot burden her with a name PCOS and then not do anything about it. So you have to be very careful when you diagnose and talk to her, because it's going to have lots of psychological issues also. So we have to be very careful. But at the same time, you should not miss treating her also if she's been diagnosed. Put it very gently across to the mother and the child so that they manage themselves, because this disease has got lots of long-term implications, which needs to be managed even at the adolescent phase. So I'm extremely thankful to all the esteemed panelists who joined today, Dr. Ranjana, Dr. Supriya, Dr. Kiran Trivedi, Dr. Lata, Dr. Shipra, Dr. Prabhati, and Dr. Komal, as well as the esteemed co-moderator, Dr. Kavita, as well as the expert, Dr. Poonam Dikshit. So the incidence of this disease is actually not known in the adolescent age group, even though it's in the reproductive age group, there's an incidence of almost like 3.6 to 15%, which is quite a big number. But there are no studies actually to say how much it's there in the adolescent age group. So Ranjana ma'am, what will you use as the diagnostic criteria for PCOS? What is the criteria? Because there are so many criteria available. What do you use in your practice?
First of all, very good evening to everyone. And thanks Bhagalpur Afghani Society for making me a part of this panel. I use personally, I use for diagnosis Rotterdam Consensus 2003, in which there are 3 criteria. And if in 3, 2 are present, that is diagnostic of PCOS. First is ovulatory dysfunction, which is either oligomenorrhea or anovulation. And second finding is hyperandrogenism, which is either clinically or biochemical features. In clinical either acne or hirsutism, or very rarely alopecia also. And then third is morphological features, which is seen on ultrasound finding of ovary, which is a string of pearl appearance, in which we see there are 2 to 9 millimeter follicles in one of the ovary, more than 20 in number.
Do you still consider an ultrasound diagnosis for an adolescent?
Yes, no, for adolescent, I do not consider. But because up to 8 years after menarche, now ultrasound multiple follicles in the ovary is normal. So for adolescent PCOS, I do not use ultrasound
Yeah,
findings.
that
I
is
do
the
ultrasound. I do ultrasound for other findings, but not for diagnosing PCOS.
Yes, clear. So it should be either a clinical or biochemical hypoandrogenism. So if she has got hirsutism, she has got acne, she's hypoandrogenic. You need not go and do a biochemical test. That's Rotterdam's criteria. Second is oligoanovulation. She gives a history of irregular menstrual cycle. Then that is a part of the oligoanovulation side.
And for
Part of
up
the
to 2
diagnosis.
years, even up to 2 years of menarche for adolescent girl, it is not taken as a diagnostic criteria.
Yes.
Yeah.
So there are very clear categories put up in the recent consensus of Rotterdam that was in 2018. So 2003 is not considered as absolute for a adolescent. You take only two: menstrual cycle pattern and the hypoandrogenic features. You do not take an ultrasound diagnosis of PCOS to put under the category of a disease. It's only two. So that's very clear now. So these are the categories which are put up in the 2003 criteria. And you need to always exclude certain disorders before you put her as PCOS. That you have to be very, very clear when you're diagnosing the disease. Rule out congenital adrenal hyperplasia, rule out an androgen secreting tumor, rule out Cushing's, rule out a thyroid dysfunction, as well as a prolactin disorder before you put her under the category of PCOS. Dr. Supriya, what is a caution which you will follow while diagnosing PCOS in an adolescent, and what will make you suspect PCOS in an adolescent?
Good evening. At the outset, I'll really thank Dr. Rekha Jha, President ISO, President Bhagalpur OBGY Society, and Dr. Kavita Barnwal for giving me this opportunity. Thank you very much. And Dr. Charmila, nice to be in your panel. Yeah. And then, so during
this question I put it to you because having a menstrual irregularity, as Dr. Ranjana said, is quite common for an adolescent in the first 2 years, which you've seen quite commonly. Hyperandrogenism also is quite common in an adolescent. If you put an ultrasound, you will see a polycystic ovary in many of the adolescents. So it's almost common to both. So how are you going to put your picture across saying like she may be a polycystic? That's my question. Like, what is a caution which is needed? When do you suspect that this girl can be a PCOS patient?
Yeah, see, the history of irregular menstrual period and high BMI, once the girls enters the clinic with a heavy body weight, obese, then they usually complain of you can see the male pattern of hair on her face and all these things. These you usually suspect. This clinical presentation first gives you an idea that this girl could be a case of PCOS. Most of the time I have encountered even lean PCOS, but then most of the time we have this type of girls coming to your clinic who usually the period of amenorrhea 3 months, 6 months, they usually come with this history, irregular spotting in between. Then getting suddenly they'll say I gained weight over a period of 6 months. These are the regular features, and we don't need to overdiagnose, but ultrasonography, real pattern of the ovaries.
No, that's what I'm saying. You don't need an ultrasound at all. So your suspicion starts. She's got a very abnormal pattern, as you said, like more than 3 months, or she gets a menstruation only with drugs, and all that strikes your mind. Second is the overweight, the BMI. When
the
it's
BMI,
more,
yes.
Lean PCOS can have, but when the obese adolescent enters your OP, you have a suspicion that this girl can have a PCOS pattern.
PCOS,
Third thing is early, that early telarchy, early adrenarchy, like she's had a pubertal hair growth even at 8 years, 9 years, and this girl has come with a problem of irregular periods now. Keep that in mind, because early changes, or sometimes she would have been secondary amenorrhea, like 16 years, not attained menarche. This girl also you should have a suspicion. And when, as you said, that severe hyperandrogenism, that early acne, hirsutism, lots of hair on the face and body, persistent acne, that you should keep in mind.
At a very less age only, they start getting the hairs, upper lip hair, more on their back, arms, hair, hairy legs and feet and hands also. So you can suspect straight away that she can be a case of
PCOS. And one more thing is acanthosis. Always look for it. If you see acanthosis in a young girl, she's more likely to be a PCOS, and that with the additional complication of metabolic problems setting in. So when you see a girl, you see lots of hair growth. She complains of very irregular patterns, says that she had early adrenarche or early telarchy, or she's had secondary amenorrhea, or she's had a very striking feature of acanthosis and all that, you have a suspicion that she may be a PCOS. Thank you, Supriya. Thank you so much. Dr. Kiran from Ranchi, she rang me up today. I'm so happy to meet you here. This girl, she's 14 years old, has got a BMI of more than 34, and she comes with a mother to you, which usually happens, and they complain of oligomenorrhea, and when she bleeds, she's got heavy episodes. And the mother is actually worried about the delayed cycles because she's worried that this girl may have problems in conceiving later on, but the girl is worried about her appearance. So how will you actually classify menstrual cycle patterns in adolescents? Dr. Anjana has touched upon that, but I'll just ask you to briefly say, what are the menstrual cycle patterns in an adolescent which has been labeled by Rotterdam consensus of what should be taken as a pattern which needs investigation and a monitoring?
Good evening, everyone. Kavita Bandwalde and Dr. Rekha, I am thanking them for giving me opportunity to join here. And thank you, Charmila ma'am. So we all know, and the previous panelist has told clearly that initially we all know that initial cycles in adolescent girl when she attained menarche are irregular because usually they are anovulatory. So always whenever the patient comes to us and she tells us that she had irregular period, only if that is the problem, we counsel them that it is the normal occurrence. And if it is persistent, then only we need to treat it. So we usually tell them to make a menstrual calendar and we wait. But here the scenario is different. The girl is quite obese and the BMI is very high. So we should suspect that she might have a case of PCOS.
Yeah. So actually, these are the patterns which we need to be very clear about. Suppose she has come with an irregular cycle just 1 year within menarche. That you take as always as normal pubertal transition. You do not label her as a menstrual irregular patient. Suppose she comes 1 year post menarche, and if she reports even one cycle which is more than 90 days duration, then you say that she may be a PCOS. Suppose she comes 1 to 3 years post menarche, but now she has got a cycle pattern which may be less than 21 or more than 45 days. Then you put her as a suspected pattern for irregular cycles. Suppose she comes 3 years post menarche, but now her cycles are less than 21 or more than 35 days. It's not 45, it's 35 days. Or she has just 8 cycles in a year. She misses 4 cycles, 3 years post menarche. This also is a suspicious pattern for a PCOS patient. Or if she comes with primary amenorrhea up at the age of 15, or it's almost like she's attained a thelarche, breast development is good, which has not had a periods even for 3 years post thelarche, then also you're suspicious that she may have a PCOS, because this criteria has been put up by Spearhoff as well as by Rotterdam. So this we have to be very clear, the age of the girl when she comes with a menstrual irregular pattern, and how are you going to classify her. So Dr.
Madam,
Lata,
we can take expert opinion also. Expert opinion.
Yeah, at the end of
Ma'am, I want to add one thing also.
Yes,
that whenever the patient comes to us, it's she is an adolescent girl. We always want to see the height, weight, and features of hyper. If she is a short height, we should think about other things. If she presented with primary amenorrhea, secondary sexual characters are not present, then we should see for ovarian dysgenesis and all. And if she comes with normal height and normal secondary sexual character, it may be due to constitutional delay. Also, if again we are giving after few years.
See, this is like basically we are not evaluating for primary amenorrhea. This is like she has a pattern of primary amenorrhea, you have a suspicion. That's all.
So if she has secondary sexual character and she is not attained menarche, then we should suspect that.
Okay. Perfect. So Dr. Lakta, what are the diagnostic tests for exclusion of PCOS? What are the tests you will do to exclude PCOS?
We have to examine clinically first. If she's obese and has the symptoms of hyperandrogenism, then we might to think about PCOS. So sometimes we might be confused because these patients, the characteristic of normal puberty character also overlap. So first I have to, if she comes with, according to her symptoms, I'm going to do the diagnostics test. If she comes with the history of amenorrhea, first of all, I have to rule out pregnancy? Is she having any hormonal problems like thyroid test, then hyperprolactinemia, and I have to rule out the congenital adrenal hyperplasia also. Sometimes we can also, because they are prone for hyperinsulinemia, we can advise glucose tolerance test, which is very important. 45%.
Ma'am, not for excluding PCOS. That's a part of the PCOS testing for excluding PCOS, because there are other conditions which can mimic PCOS. So we need to exclude.
Yes, madam. You have to do mainly the total testosterone and even DHEAS to rule out the androgen producing neoplasms.
Yes.
Usually in this PCOS testosterone is rise, but it is not very high. When the testosterone levels goes more than 200 milligram, then we can suspect it might be a case of virilizing tumors. Even the DHAs, if the levels go above 800 milligram per DL, then we can suspect the virilizing adrenal tumors. And we also have to do the 17-hydroxyprogesterones. These levels to rule out congenital adrenal hyperplasia. Usually the normal levels are 2 milligrams per DL, and if it is more than 5 milligram per, then we can think of it could be a case of 17-hydroxyprogesterone. And we have to rule out Cushing syndrome also. Here we have can do 24 hours urine for free cortisol, and 1 milligram dexamethasone suppression test can be advised in such cases.
Yes, perfect. So you ruled out all the other causes of PCOS, but actually, if you have a suspicion of the physical findings, do not spend so much money on other tests unless you, as Madam had said, you have to be very careful about the clinical examination. That will point to what you need to do, because doing a DHAS for 800 rupees and doing a cortisol for everyone is not feasible. Thank you so much. May I request Poonam to give an expert opinion on how would she consider a person as PCOS? Adolescent who comes to a PCOS, what are the clinical features which will make a suspect? Poonam?
Thank you, Shamila. We have already heard from the experts that high BMI, any hirsutism, acne, and irregular periods, which are the traditional signs. And based on that, we go for diagnosis. What I would like to emphasize that we should not order ultrasound for these girls.
Yes.
Because that's a very common practice. What is happening in clinics these days? The girl comes with the ultrasound that I have been diagnosed PCOS. So we have to go backwards and then emphasize. Another thing I want to highlight is a lot of these girls these days, we have to check whether they are on any medication, antidepressants, which can cause irregular periods, weight gain. So that also a clinical point we have to do.
Very practical. We need to think about the other causes also before you put it across to whether she's PCOS, because as Poonam said, many of them come with an ultrasound report of PCOS, and it's very difficult to actually convince them otherwise that it may not be that also. So it's very difficult at this point.
And look at the mother, when we are saying, say if the mother is very slim and short and the girl has got a BMI of 30, 32, then that is a very strong pointer towards PCOS.
Yes. Shipra, how do you manage PCOS in an adolescent?
First, the manager should have a proper counseling of the patient. You have to gently break the news to her and tell what PCOS is all about. Nowadays, the patient, they come, they study from the Google, everything. But we have to tell first step in the management is lifestyle modification and reduction of weight, calorie restriction, and daily physical activity for at least 30 minutes per day should be recommended, and healthy and balanced diet, which consists of regular calorie restricted meal, avoid the sugary food, fried food, and green leafy vegetables. They should take complex starch in their food and at least not more than 50% carbohydrate in their food, and routinely screen for BMI and base circumference index for increasing adiposity and development of hyperandrogenism, and calorie restricted diet, that is low carbohydrate, fat, and high protein diet should be given. Lifestyle modification is the first line treatment for at least 6 months. Then second line, we add the insulin sensitizers like metformin we usually use.
Okay. Thank you, Dr. Shipra. Thank you. Dr. Prabhati, how do you regulate menstrual cycles? What is your option after lifestyle management? What are the drugs you prefer? Okay. Dr. Prabhati, she's there?
There.
Can you, yeah, please unmute. Yes.
I thank the Bhagalpur Obstetric Society President and the Secretary Madam to give me an opportunity to participate in this program, and thank Shamila Madam that you are here for the expert comments and moderating this session. In a PCOS case, when there is menstrual irregularity, we can first we have to counsel the patient and give the lifestyle modification counseling we have to do. Weight loss, Dr. Shipra has already mentioned. We can give her low dose OC pills. We can give her medroxyprogesterone acetate tablets, and we can ask her to avoid all the bad habits like having alcohol, smoking, psychological stress if she has, so that the condition improves and the menstrual irregularity gets regular.
Yeah, thank you, Dr. Prabhati. Komal, the adolescent of the group. What do you think about combined oral contraceptives in adolescents? Because many will ask, you're giving a family planning pill to my daughter at the age of 14, 15. Do you think it's available, advisable? And what are the anticipated problems when you give combined oral contraceptive pills for a young girl? Komal?
Thank you, ma'am, for giving me the opportunity. The oral contraceptive pill to be given in a patient with PCOS, we should go for third or fourth generation progesterone. Third generation, like which has low androgenic activity, lowest, and the fourth generation, which are anti-androgenic. So we can give Familon or Novelon or fourth generation combined like cyproterone acetate with ethinyl estradiol, diene 35, or yes, or drospiron 3 mg.
No, what I'm asking is, you give combined oral contraceptive pills to a young girl, her bone age, you are worried about that, or you think it's okay if you give OC pills for a girl who has not attained her full height?
Yes, ma'am, it is a matter of concern, but we generally go for it because, and we try to give the lowest low dose of estrogen.
Yes, yeah, because the problem is, even though there are studies which have said it will not cause any problem with the peak bone mass development, there is a concern when she's just 2 years within menarche, because the plates would not have closed by that time. So it's better if you avoid it for very young girls around like 14, 15. And what the study says, you can use it very comfortably if she's above age 16, because by the time her height should attain that height. So it may not help. It may not cause a problem there. But suppose she's around age 12 to 16, it's actually Spearov's guidelines. What they say is, you give it for a very short period, like a progesterone. Give it for 7 days in a month, that's all. Let her get her period like that. Or you can give it like every third month or something like that. Give her a course of OC pills. So that works much better than giving a continuous duration of OC pills, because that concern is there. And suppose she's one girl who does not gain height after that, you will be blamed for that. So just keep it in mind when you're prescribing oral contraceptive pills for a very young girl. May I ask Poonam her opinion before we go on to the next, and that will be taken up by Dr. Kavita. Poonam, your opinion on management of irregular cycles in adolescent PCOS?
So much depends on how irregular they are, sometimes we can just give, if she's able to follow lifestyle modification, we can give her progesterone for withdrawal bleeding, because that makes her feel better. If it is really very, very irregular and she's not following lifestyle modification, then we should give OCP. That's a very good treatment, and that also takes care of any hirsutism she has, and any normal OCP does work for it. And a very valid point was brought about the age, and so that we are not affecting her height. So I follow the 16-year age gap, and also compare the height, whether she has, if she's quite tall, and then we can sort of safely give her OCP. And OCP is my first line of treatment combined with the lifestyle modification.
Yeah. Perfect. Thank you, Poonam. Kavita, can you continue, or shall I do it?
Okay, madam, I will try to do, but you have done so well. इसलिए you have not to mind it because I may not do like you,
No.
but still I'm trying. So this question goes to Dr. Ranjana. We have seen many cases with PCO, PCOM, PCOA. So what is the difference between three and what are the, in fact, two, and what are the phenotypes of polycystic ovarian disease? So can you explain, Ranjana? Hello, Ranjana. You see there?
Yes. And I was muted. So, PCOM is the morphological finding of the ovary, PCOM, which I had already discussed. That is 2 to 9 millimeter ovary, more than 20, peripherally arranged, and a volume more than 10 ml. A volume of ovary is more important than the number of the follicles. This is PCOM. That is the morphological finding of ovary by ultrasound. And we all know that PCOS is the multi-system heterogeneous endocrinopathy in reproductive age group in which there is ovulatory dysfunctions and lots of problems such as menstrual irregularity, obesity, and hirsutism. And phenotypes of, there are 4 phenotypes, A, B, C, D.
Madam, please move here. Move the slide there.
A, B, C, D. A is most common and C is very unnoticed phenotype C. A is in which all features are present. That is ovulatory dysfunction, ultrasound finding, and clinical features of or biochemical features of hyperandrogenism. And in B, there is hyperandrogenism along with ovulatory dysfunction. And in C, hyperandrogenism with polycystic ovaries, and D is ovulatory dysfunction with the morphological findings on the ultrasound. A is most common, and C is very unnoticed.
Yeah.
The most common, very much noticed, A is.
So PCOM, finding of PCOM is not, I think, very serious condition. PCOS is more, I think, a dangerous thing. Is it right? Because this is syndrome and PCOM is just ultrasound finding. So I think PCOM may be normal, but PCOS, if you find PCOS, then we have to see it seriously. So this question goes to Dr. Supriya. A girl 23 years old with features of hirsutism and BMI 24. Just borderline, presents with masculine look, and say that she is not able to concentrate in her studies because of her look. She is very upset with her appearance. So how will you counsel and treat her? And what are other clinical manifestations of hirsutism? So Supriya?
Yeah, thank you, Kavita Di. It's this, by looking at this patient and her mental disturbance, because these girls, young girls, when they get such type of features, they get really anxious and they are very conscious about their look in this age. So this, it is sure that it seems to be a case of PCOS with whatever we can see here in this case. So we have to measure all this waist hip ratio, psychological support. See, I usually really telling you, I counsel a lot. We don't refer for the professional counseling, but I personally counsel all the PCOS girls along with her mother not to worry when she's not losing weight and all. So they try to make her starve, and sometimes the PCOS girls, that because of that they go for early going off for removal of hair, facial hair, and all those things. I try to tell them to lose weight, to modify their diet.
She is in PCOS, Supriya.
Yes.
BMI is 24.
Yeah. But then also, I counsel her to
lifestyle
not to worry
modification.
much.
Lifestyle
modification. Yes. That is the main thing. Actually, they are these facial hair, whatever you have, other manifestations, as everybody knows, the acne, acanthosis, irregular menses, these things, hair loss, and that baldness makes them more worried, and they become really upset because the hair thinning out of the hair, and mostly of the upper lip hair and the facial hair. These things really, and later on that goes to infertility. That is very common, and once treated, it really helps PCOS.
Yeah, well explained, Supriya. So Poonam Di, do you want to give your comments, expert comments?
No, I think she's covered everything. So we move on. Thank you.
Okay. So Dr. Kiran, are you there? So how will you treat this case, Kiran? If the patient comes to you with the features of hirsutism, how you will start treating her?
So first of all, Kavita, we will see that what is her BMI. Here the BMI in your case is 24. That's not much. That is within the normal range. But nowadays, the adolescent girls have very irregular sleep pattern, no lack of exercise, lot of junk food intake, and lack of nutritious food intake. So first of all, we will see to imply her on lifestyle modifications so that the androgen level will she will lose weight and her cycles will be regularized and the hirsutism will be taken care. Second thing we can give, she is quite young girl, so previously it was talked that within 2 years or 3 years menarche we should not give long term COCs. So for hirsutism we can give very low dose pills which is available nowadays, drosperinon with ethinyl estradiol, that is 30 microgram and 3 milligram drosperinon. So that takes care for acne, hirsutism well. But if she had lot of hairs and at present it is there, it is not very it is not going to be removed by taking these medications. So we have to refer them for specialist care, and epilation therapy, laser therapy can be taken care, or cosmetics cosmetic treatment by derma specialist. But few of patients can be put on spironolactone. The dose is 100 to 200 milligram per day, but we should give with caution. And in adolescent age group, there is no need to give backup therapy. But if the female is more than 18 and she is married, backup therapy with COC should be given, because if she get pregnancy, so feminization of male fetus may be there. And cyproterone acetate is again a good choice. Few anti-androgenic substances are there, flutamide and etc., but we are not giving regularly those. So we are referring the patients to skin specialist for those.
Any topical cream, Kiran, which can be applied? Though it will not work immediately, but after removal of the hair by laser or electrolysis.
So epilation and removal of hair is the main treatment, because permanent removal of hair is, and then we can apply that cream.
Sometimes we are using
Eflornithine hydrochloride. Eflornithine hydrochloride. Yeah. Is there any role? Eflornithine hydrochloride.
Practically, I'm not giving
sometimes
too
I'm
much
using
patience.
eflornithine cream.
Yeah.
It works. It works. It can be used.
Yes.
It can, after 3 to 6 months, I think it helps to prevent the growth of the hair.
Further hair growth can be taken care by drosperinon and cyproterone acetate containing pills.
Yeah.
And
Thank you. Puramdi?
Yes, yeah, that cream works. What I want to add is that the regular pills also help in hirsutism. So we don't, pills containing cyproterone, they are quite expensive, and many of the girls, they do not comply. Of course, we should switch if the hirsutism is really bad. And the other thing is that we have to allow minimum 6 months for them to act. This has to be counseled when we are prescribing OCP or any OCP, the regular OCP or cyproterone containing OCP, that is the time frame which we are looking at. It's quite resistant, the hirsutism has to be, it goes very slowly. So, and by then the girls, they lose patience and they go for all these cosmetic treatment.
Actually, she becomes depressed and anxious. We used to see such patients, they are very anxious. They lack concentration, so we have to be careful, and I think hirsutism should be treated immediately. Thereafter we can go for other methods. So this question goes to Dr. Lata. So how you will treat acne and obesity? So such cases we find not daily, but sometimes we find once a week. So how you will treat? And
an adolescent girl with an acne really suffers from depression. She wants treatment for acne very immediately. We can advise them that they should keep their face clean, but excessive washing should not be advised. Local exfoliants like salicylic acid can be advised. Antiseptic application of benzoyl peroxide can be helpful. And we can also prescribe the local antibiotic ointments like clindamycin and erythromycin. Sometimes the retinoids can be helpful in such cases. Sometimes the acne are very, they would not respond to the usual is normal treatment. Then we have to give oral antibiotics like doxycycline can be given, erythromycin can be given, minocycline can be advised. Isotretinoin 0.5 to 1 milligram per kg body should be advised. The cumulative dose is 120 to 150 milligram per kg. It has to be given for a period of 6 to 9 months. In severe forms, when nothing works, then we have to give her cypritone acetate, the oral contraceptives, these at least for a period of 6 to 9 months. These can be really helpful. And coming to the obesity. Obesity itself is again or adolescent girls, when she's obese, she undergoes depression. She has lost her confidence. So we have to motivate them for the lifestyle modification changes to reduce her weight by exercise and proper diet. We advise, but it is not an easy thing to do. So motivation should be very strong, and we have to give her a positive attitude that she can do it any cost. So proper exercise, at least 30 minutes exercise per day in a moderate way should be done. She can advise the yogic exercise also, and meditation to keep her mental status, because we all know they suffer from lack of concentration and depression. That also improves her. Reducing the weight itself will bring down the androgen levels down, even the insulin levels down, and it can help in many ways. And about the diet, proper nutritious diet having a good micronutrients should be taken, particularly like omega fatty acids. The diet should contain less carbohydrates and at least 25 to 30% of proteins.
Yes,
And this
yes.
protein should be taken at the time of the breakfast rather than the lunch and the dinner. And you should have high fiber diet, and there should be less of
thank you, Lata. You have explained well.
glycemic index.
Yeah.
So all this can help to reduce our obesity. Thank you.
Even 10% weight loss can help to great extent. Madam Charmila ma'am, so now we take other two questions.
I think another one thing, we have to see that the energy deficit is 500 to 1,000 per
calories.
This helps.
Yeah, thank you, ma'am. Dr. Shipra, what are the long-term complications of adolescent PCOS, which you have to counsel the mother and the child?
Because of the unopposed action of the estrogen for a long time on the endometrium, there is a high risk of developing endometrial carcinoma. In fact, in some few patients have seen an increased risk of ovarian carcinoma and breast carcinoma also. And because of hyperinsulinemia, there is increased incidence of type 2 diabetes. Impaired glucose tolerance is there, and there is dyslipidemia. The lipoprotein profile is altered and leading to cardiovascular risk and atherosclerosis. And obesity and the other related side effects are there. Obstructed sleep apnea.
More than the long term, when you keep on telling about cancer, they get totally psyched out. So actually more should be concentrating on the metabolic features.
Hypertension, the metabolic syndrome.
Features
the type 2 diabetes, hypertension, dyslipidemia, cardiovascular risk, and obesity and the related problems, they're psychological.
Yeah. Thank you so much, Dr. Shipra. Dr. Prabhati, what are the psychological issues in an adolescent?
In an adolescent patient, there is a high rate of anxiety, depression in women and adolescent PCOS. Routine screening is recommended for depression in adolescent women and diagnosis. Use of psychiatric agent may worsen obesity and should be used with cognitive behavioral therapy. May be beneficial in terms of weight loss, symptoms of anxiety and depression. Specific recommendation on regular weighing are made. Actually, madam, there are a lot of studies also that a patient undergo depression and there is poor quality of life due to the peer pressure, and she wants to, and the young girls always want to live smart and beautiful. So counseling is better, and if she is having any type of depression and anxiety, that should be counseled and counseled. much more than putting them on anti-anxiety or
that's a very, very valid point. When you tell a
Yeah.
young girl that she's obese and she's going to land up with so many complications she already talked about, it's going to totally spoil her life. So be very, very careful when you're putting words to her, because that's going to cause more of problems. And that was a very valid point when you talk, because sometimes nowadays we are seeing children going for bulimia and anorexia nervosa, because you talked about PCOS and its complications so much that they keep on eating and then vomiting it out also, and they'll end up with so many complications. Be very careful about that picture also, which is you're seeing quite commonly now with those school-going girls when you put the picture of PCOS here. Thank you so much, Dr. Prabhati, for that valid point. Poonam, would you like to say something?
No, I think very well covered about what she's. I just want to ask everybody: this cognitive and behavioral therapy, is it available widely?
It's actually a part of the psychological like counseling which we give. So it's mainly they have to change the behavior. No, it goes in a pattern wise. They have a specific protocol of managing these girls, but most of the times they do not go when you put the word a psychologist. They say that I'm not having a mental issue, I'm not going. So the basic thing is you have to learn how to counsel your young girl who comes to you, because they usually do not go to psychologists, but sometimes it is very, very severe. And they even go for suicidal tendencies. So you have to be very careful with that one group of girl. Which can
Madam, in our town we have Bal Yoga Mitra Mandal, which covers adolescent age group. It's under Swami Niranjananji, and they do exercise, Surya Namaskar, and all the asanas as well as meditation. I think so. In our part, though they are suffering with PCOS, but most of them remain comfortable. So we have Bal Yoga Mitra Mandal in our part. Almost all school children have joined that community.
I think we should extend it to other places also. That's excellent.
Thank you. So actually, we have to be very careful about that potential negative psychosocial impact when clinical hyperandrogenism is there in the form of hirsutism and acne, which most of the panelists put across. Very, very careful about when she complains about hirsutism. Please take a note of that. Don't say that it's not so much. Don't worry, nothing will happen, because it's worrying her. She's asking you. So you have to put it in the proper perspective. So when you guide a PCOS girl after diagnosis of PCOS, please break the diagnosis very, very gently. Explain what PCOS is to her. Emphasize on the need for long-term management. Counsel on lifestyle modifications, which are diet and exercise. Explain on every different treatment option available. Emphasize on the need to be adherent to therapy, because they usually take, leave off, come back again. It becomes a yo-yo therapy, and many times it never creates an impact on the family or the girl. And always ask her to look out for the warning signs of metabolic disease, and as Dr. Shipra said, sometimes even cancer. So to be very, very careful about that. Dr. Komal, is there any role of myoinositol in an adolescent PCOS?
Yes, ma'am.
You use it? Okay.
Yes, ma'am. We prescribe it. It usually has a insulin sensitizing activity. So it decreases insulin and androgen production.
It actually sensitizes the peripheral receptors. That way it acts as a sensitizer. So yeah.
It acts as a secondary messenger and regulate various hormone like thyroid stimulating hormone, FSH, insulin, and
Now, I would like to ask, how many of the panelists use myoinositol?
Myself.
Madam, I use. I also use, madam. I have found good results.
So what I would ask is, Bhagalpur Society, you take the correct data. You formulate a study. Because myoinositol is not being advocated by any guideline. It's supposed to be a food supplement. So we have to put up the proper data to say it's useful in a adolescent patient.
Yeah.
So the benefits as
Poonamdi, do you use it?
Not much.
But
it works well when metformin is added.
It's very costly but effective. We are giving. If the patient is willing to take, it is costly, but we are giving and getting results, ma'am.
Sometimes it's like similar to metformin, it causes so much of gastrointestinal effects. That's what else also I've seen. So to be very careful when you're telling them to take. So actually, I would like to wind up by saying regarding the Rotterdam Consensus of 2018, because this consensus is the one which put up the adolescent PCOS in perspective. And they said it's very challenging to diagnose PCOS in an adolescent, because menstrual irregularity, multifollicular ovaries are all part of the normal pubertal physiology. And so when you apply an adult criteria as in the Rotterdam's consensus of 2003, it results in actually a high prevalence, and you may actually overdiagnose PCOS because every adolescent is going to have menstrual irregularity and multifollicular ovaries. So what they have said is, in this recent guideline, they've updated it to saying that only oligoanovulation and hyperandrogenism should be considered for diagnosis of PCOS in an adolescent. Avoid polycystic ovarian morphology as a diagnostic feature for adolescent PCOS. And the key driver of severity we need to identify in the adolescent PCOS, because you cannot underdiagnose or overdiagnose, as many of the panelists say. So we have to be very careful to put the proper diagnosis, the proper perspective for a girl who's being diagnosed. For that, they say you take hyperandrogenism and menstrual irregularity. And when they have a risk of excess weight gain, which I think one of the panelists said, like suppose she's put on weight in the last 6 months or something like that, this is a key driver of PCOS severity. And this group should be targeted for early lifestyle intervention and prevention of PCOS. And that is, if you do not have a diagnosis of PCOS, there's one category which is at risk. And this at risk category is the one who's putting on weight and already is having hyperandrogenism and irregular cycles. Here, appropriate symptomatic treatment should be started. Regular reevaluations should be done. And the menstrual cycle reevaluation can actually happen 3 years post-menarche, because up to that, you can even consider as a normal pubertal transition. But if it happens even 3 years post-menarche, you need to do a reevaluation. Always screen for anxiety and depression in young girls, and the assessment of eating disorders always warrants consideration in a adolescent girl. So to wrap it up, it's a challenge to treat a PCOS patient, and that in the adolescent group. Always a treatment should be tailor-made, address a root cause which is causing that particular problem. Lifestyle change and exercise should be a part of a PCOD management. And the treatment is diet, exercise, drugs. Drugs can be metformin, OCPs, or myoinositol, as many of the panelists said. Thank you so much for a patient hearing. May I ask Poonam to give her export comments before we finish the panel. Thank you so much.
I just had one more thought which I wanted to present before everybody.
Yes,
the intermittent fasting. It has come up in a big way. Jason Fung has written a book on PCOS and emphasizing that it reduces incidence of hyperinsulinemia. And having read it, and I think it is something we should advise them and maybe do a prospective study to see whether it works or not.
It never works for me.
Pardon?
I try intermittent fasting. It never works for me.
Yes, I also agree, Dr. Charmila.
Not all lose by intermittent fasting. So you
Yeah.
have to actually cut down your calories, 50% of your calories, then you lose weight. Then I'll become like Pratibha after that. Yeah, thank you so much, Dr. Kavita, for a wonderful moderation. Thank you. And I would like to
Madam,
thank
you have
all the
done
esteemed
so
panelists.
well.
Thank you.
So just now is the part of Thanksgiving ceremony. So on the behalf of Bhagalpur Afghani Society, most humbly and sincerely, I extend my heartfelt thanks to Chief Guest of today's evening, Alka Kriplani Madam, who in spite of her busy schedule could join today's webinar. My sincere and heartfelt thanks to Vice President East Zone, today's guest of honor, Vasu Mukherjee sir, for inspiring words. I am very much thankful to speakers of today's evening, Dr. Girish Mani sir, who spoke so well on Adolescent Lodge, and we learned many new things, including different acts, and we should follow it in our day-to-day practice. I am very much thankful to Rekha Madam, who spoke so clear on adolescent DUB. Though in the morning she was saying, I have not prepared well, but she spoke so well, and especially in Hindi. So I liked it because it's our mother tongue, and she made us clear that we can speak in English as well as Hindi also, so that everyone can understand. My sincere thanks to chairpersons of these two sessions, Dr. Pratima Modi Madam, Dr. Rajni Madam, Dr. Anju Triyar Madam, and Dr. Priyankur for chairing the session in brilliant way and keeping their input. I am very much obliged and thankful to Charmila Madam, who helped and worked in preparing these slides for the panel. She was so busy earlier. I met, but later on she considered my some slides, but she did it better. She is an epitome of knowledge, I think. My heartfelt thanks to expert of today's discussion, Dr. Poonam Dikshit. She is very close to us. I was earlier in Patna Afghani Society, and she always used to talk to me and keep me in panel and other things. And really, she is very academic and very brilliant. My sincere thanks to all the panelists, Ranjana, Supriya, Kiran, Sipra, Lata, Prabhati, and Komal for participating in this webinar and making it useful. I am thankful to all the delegates and viewers who made this webinar meaningful. Last but not the least, I am thankful to our dynamic President Rekha Madam, who works so much and so hard. Really, I think I only do 10% job, and remaining 90% is done by Rekha Madam, and she is always helpful. Whenever I call her, she remains ready. Okay, kar lo, jo tumhe karna hai kar lo. So really, she is very supportive. I am very much thankful to. And lastly, I am thankful to convener of today's webinar, Dr. Pratibha Di. She is also very helpful, and whenever I call her, she remains ready. Kya chalo, aisa karo. She always guides me. So I am really thankful to you, Pratibha Di. Lastly, I am thankful to SIL people who make this webinar so successful and give us platform to meet so many people. So thank you so much, and good night.
Thank
Good
you.
night.
Thank you,
Rekha
madam,
Madam,
for
do you
giving
want
us
to add
the
anything? Rekha
Thank you.
Madam, and best of luck to Pratibha Di, Priyankur, and Supriya. All of you.
And Dr. Sharmila.
Charmila Madam is unopposed. I think Charmila Madam
Charmila
is
ma'am.
Unopposed.
but
Priyankur is not here, I
all the
think.
best.
Thank you, Rekha
Thank you,
ma'am.
Rajni Madam.
रेखा मैम थैंक यू बहुत कुछ सीखे
Supri-
बहुत
Thank
कुछ
you.
Good
Thank you,
wishes to
Pratibha Di.
Supriya, Pratibha Di, and
Thank you, Dr. Mane sir.
Dr. Mane, I would
Priyankur
like
sir.
to speak something. I would like
Dr. Mane
just
sir, एक गाना
एक minute. I would like
सुना
to
दीजिए
speak.
सर।
एक minute. Pratibha. I would like to speak something. I would
बोलिए
like to
madam.
tell Dr. Girish Mane one thing, that whatever you spoke about the laws, can you not write down a booklet? You were talking about booklets. Can you not prepare a booklet so that it is an easy referral for all the gynecologists? It can be an easy referral. It can be, it will
Actually,
be.
madam, I have written one chapter for Foxy.
Yeah, it is in the
I have
medical
written one chapter on Foxo.
Is it available online? Is it available online?
Madam, it is on AICOG guidelines. No? There is few booklets on the medical legal books. So it is there in that.
Okay.
Yes.
We can
Actually,
get
I'm
it from
prepared.
there.
Yeah, I'm prepared with the chapter. Actually, I have given 6 to 7 chapters, so I'm not recollecting to whom I have given this. But definitely, I'll pass on the message of that book, and definitely it will be available for everyone.
Yeah, sir. It is in ICOG that book we get. No, there is a book on medical legal book is there, and we have
One book is written by Dr. Sanjay Gupta sir. Dr. Sanjay Gupta sir has also written book.
Last AICOG.
There are many chapters. One of the chapters I have written on Foxo, so it is ready with me, no issue.
Okay.
So yeah, so I'll definitely pass it on.
Before we end, sir, 2 lines सुना दीजिए गाना, sir.
Yes, sir. Yes.
Dr. Girish Mane, yes.
मेरा रिकॉर्डिंग सुना तो मेरे पास रिकॉर्डिंग्स है इसमें तो
नहीं सर, आप सुना दीजिए ना। इस बार कंपटीशन होगा सर। एक डॉक्टर नयनमणि विश्वास है, हमारे टाउन का ही है, वो एक्चुअली है कलकत्ता का।
हाँ, नयनमणि जानता हूँ मैं, बहुत अच्छे से जानता हूँ मैं नयन को।
ओह अच्छा, वो हमारे एरिया में सर, वो जमालपुर में है ना, रेलवे में। इज वेरी गुड सिंगर।
हाँ, पता है।